Yes.
Sir, I'm ready now.
Yes, sir. Thanks.
Yeah, no, might off. Good evening, everyone. This is
Good evening, friends. Thank you for joining us and sorry for the delay and connectivity issues. Today we have very eminent faculty joining us. We have Professor Thomas and Professor Babu sir, very eminent teacher of teachers and trainer of trainers from Kerala and national faculty in multiple programs, honoring us by joining as a guest faculty. And we have our own faculty, Professor Raji Sahai sir, Kanna sir, others have joined up. And we have invited faculty, Professor G.V. Manohar sir, Professor of Surgery, retired from Government Stanley Medical College, now Professor of Surgery at Manakula Vinayagar Medical College, Pondicherry. We have Professor Uday from Jupmar, Professor of Surgery there. Professor Gunabi is Professor of Surgery from Assam Medical College, Dibrugarh. And we have Professor Sunil and I would say Professor Robinson as the one who has been helping us to assemble all the classes, and he's been keeping in touch with various faculty and the student, and has been following it up. And I hope Dr. Tarun will be joining us shortly. And we have the professor and the head of the department, and we have the unit chief, Professor Sunil, also joining us today. Can I have the honor of inviting Dr. Robinson to introduce Dr. Thomas sir and Dr. Babu sir, please?
Good evening, sirs. Good evening, teachers. We will be having a presentation today on neck swellings and mass per abdomen. We have eminent faculties from almost north, south, east, and west for this program tonight. We will be also having two eminent emeritus professors for our program from Kerala. We have Dr. Professor P.T. Thomas, sir, who is a generational teacher, and Dr. Dayana Babu, sir, who is a very famous author of Pearls in Clinical Surgery. Sir will be joining us late because he is preparing for a CME program of the ASI for tomorrow and day after. Thank you very much, sir. So I think you can take over so we can start.
Thank you very much. Vioma, please introduce yourself, head of the unit, and then you are head of the department, and start your presentation. I would request all of you to be in mute mode. Vioma?
Yes, sir. I'm starting.
Yeah. I am going to mute all of you. Those who wish to unmute alone can unmute and speak. Good luck to you, Dr. Vioma. Faculty here, many of you have been faculty with us earlier. This will be a session each for 1 hour. The first half an hour will be essentially based on the history and the clinical examination. Second half an hour will be on the management issues. The invited faculty take precedence, and our own faculty also will be able to chip in for any comments or questions. So we have Dr. Vyoma is kindly contributed by Professor Shilpa Rao. She is head of the unit and in charge of the breast services at KM Hospital and State GS Medical College. So she'll be going first. And by the time I expect Geetu to sort out her presentation issues, and then she'll be presenting second. So we have a lump abdomen case to be presented by Dr. Vyoma. Vyoma, good luck to you. All the best.
Thank you, sir. Good evening. My patient, Mahesh Utwal, is a 40-year-old gentleman who is a resident of Ulhasnagar, sweeper by occupation, came to KEM with the chief complaints of pain in abdomen since 10 days and fullness in the upper abdomen since the last 20 days. Patient complained of pain in abdomen in the left upper quadrant and epigastrium, dull aching, radiating to the back, which was aggravated by food intake, relieved on medications, moderate to severe intensity since the last 10 days. Patient has also had similar complaints over the last 3 years with 4 hospital admissions wherein he was managed conservatively, last admission being 2 months back. With pain, he has associated multiple episodes of vomiting and nausea post-meal consumption, which contains food particles. It is non-bilious and has aggravated over the last 10 days, but has been present intermittently over the last 3 years. Patient also complains of fullness in the abdomen, in the left upper quadrant and epigastrium, which is insidious in onset and has been progressively increasing in size. Patient has no history of fever, has no history of loss of appetite, has no yellowish discoloration of sclera or urine, has no history of any hematemesis or blackish stools or melena. Patient does not have a history of sticky stools. He has no history of trauma to the abdomen. Patient does not give any history of significant weight loss or any chronic drug use. Past history. Patient has had history of pulmonary COX in 2008, for which AKT was taken for 6 months. He does not have history of comorbidities, diabetes, hypertension, bronchial asthma, or any IHD or CDA. He has no previous surgical interventions in the past. Personal history. Patient consumes a mixed diet, has normal sleeping pattern, and has no altered bowel bladder complaints. He has a history of chronic alcohol consumption of 90 ml whiskey daily since the last 8 years. But after he was diagnosed with these complaints 3 years back, he has stopped, has been maintaining abstinence since then. He has history of cigarette smoking, 4 cigarettes per day since the last 8 years. Family history, he does not have any significant family history. Coming to the summary of the history, my patient, 40-year-old gentleman, chronic alcoholic, presented with complaints of severe pain in the epigastrium and the left hypochondriac region, radiating to the back, multiple episodes of nausea and non-bilious vomiting over the last 3 years, aggravated in the last 10 days, with history of fullness of upper abdomen since the last 20 days. So I'm done.
Yeah, Dr. Vyoma, hang on.
Yes.
Let's go to your first. This is Dr. Sai. Just
Yes.
go to your first, please.
Yes.
Next one. Okay, you need not take the name of the patient.
Okay, sir.
Okay, chief complaints. The one which is the complaint which is earlier has to be mentioned first. The one which is later has to be mentioned.
Yes. Okay.
Basic.
Yes.
So this fullness of abdomen is 20 days and pain abdomen is 10 days. Okay, next slide, please. Okay, you described about the pain. Any relieving factors you have not mentioned? Look, in pain, you must use the Socrates site, onset, character, radiation, right? Relieving factors, all that. The whole thing has to come down. right? So there are no relieving factors mentioned here. Relieved on medication.
Yes.
Okay. Now, if he is having pain all the time, can he have normal sleep? Or does he have to take medication for
He said
before sleep?
on taking medications, then it is fine. It is relieved. Like that.
Okay. Multiple episodes continue. Food particles, is it digested? Is it undigested? How long after taking food does he vomit? Right?
Yes.
So vomit is it projectile?
Associated with nausea.
Okay. So you have to, all that has to come up.
Yes.
Fullness in abdomen. What do you mean by fullness in abdomen?
He
Is
said,
there a visible lump?
yes, sir.
So you just write there's a lump. He must be saying, I've got a lump.
Yeah, he said पेट भरा भरा हो गया है, ऊपर का हिस्सा भरा भरा रहता है.
Okay.
So on examination,
Depth of quadrant and CDS in onset, progressing in size. Okay, next slide, please.
Any
I'll just go
history
through your
of
history first and let the others take. Okay. Now, no history of negative history
Yes.
you have to have a differential and club the negative history according to each different. If it is inflammatory, all the negative history of inflammation should be there. If it is obstructive, all the negative history of obstruction should be there. If it is malignant, all the negative history of malignancy should be there. Right? If you have a differential, you can't just shuffle them all around.
yes.
Right? It's all scattered all over the place. Next slide, please. Now, past history is no history of, you should put it in medical history. If a person
Okay.
is diabetic, it can't be past history, right? It will be
Yes.
present. So, and don't say, okay, alcoholic consumption, abstinence. Next slide. Next slide, please. Next slide, please. Okay, don't make him chronic alcoholic. Chronic alcoholic means chronic consumption of alcohol. Alcoholic
Continue
means
alcohol.
he will have withdrawal symptoms on stopping. He's dependent on alcohol.
No,
Right?
not since the last 3 years. Yes, sir.
Right. So, anyone else? That's my pulse. So, please.
Yeah, Vyoma, does he have any does the pain gets relieved on any position?
So forward bending initially he said, but now he is not saying anything specific like that, because now with little pain also he takes medications.
And does
So,
he
you
will
should
have
mention that.
yeah, that
Okay,
is an
sir.
important thing.
Yes.
Mehta, madam.
Yes.
Dr. Mehta, you have mentioned in history of summary the patient with a complaint of severe pain in epigastric region.
Yes.
And in your history, chief complaint, what you have mentioned?
The
In
lacking
history of
pain. You have
present
got
illness, the lacking pain is there.
Yes.
No? Moderate to severe in intensity.
Yes.
Does any grading is there to grade the pain?
So
1 to 10. 10 is the lowest and 1 is the lowest and 10 is highest score.
subjective. Yes, sir.
And you are in your negative history, you are not basically negative history is to exclude all the differential diagnosis pertaining to the conditions. In your case, there is a pain in epigastric region. So tell me what are the causes for pain in epigastric regions? What you are thinking?
Sir, going from most common condition, normally patient coming to us with pain in epigastrium will be likely to have gastritis or peptic ulcer disease. So,
Okay.
but because he also has past history that is radiating to back and also past history, so less likely that it will be anything like that.
What other condition we have to exclude? If patient is present with a pain in epigastric region and fullness in the left hypochondriac region, which other condition we have to exclude?
Sir, CS stomach will come with fullness if he has any obstruction, gastric outlet obstruction.
So how the CA, which history we supposed to ask to exclude the CA stomach?
Sir,
Which negative history we supposed to ask?
Sir, after consumption of food, he will have vomiting of undigested food will be there. One second, within 1 or 2 hours of meals, he will have vomiting.
Okay.
and lump can be felt in the epigastrium after food or fluid intake, and weight loss history will be significant, sir. Any other history of patient can have melena also.
So you mean to say this is benign or malignant?
So this patient, sir, benign condition.
Probably benign, isn't it?
Yes, sir, probably benign, sir.
Dr. Mehta,
Yes, sir.
regarding vomiting, sir has discussed almost all things in detail. So one thing is, as rightly pointed out, whether it is vomiting is induced or spontaneous, you have not mentioned. And second thing is, you said it is not bile stain. What does it mean to you?
Sir, non-bile stain means containing acid and food particles. It's not greenish in nature. So
You said repeated vomiting. You mentioned repeated vomitings. Does vomiting give relief to the patient? It is not mentioned.
yes, yes,
Vomiting gives relief.
yes.
You said food aggravates the pain, and patient has repeated vomitings, multiple vomitings, whether it is spontaneous or induced.
So no, he doesn't induce the vomit.
Induced, spontaneous vomiting. Then why multiple vomitings? How do you account for that?
Sir, after the current situation of the patient, most likely.
Suppose the pathology is in the stomach. The patient is having vomiting. So why should you have multiple vomitings? Is it logically correct, or the interval between the food intake and the vomit, that also that has got significance.
That is very important.
Very important, no? What does the vomit taste like? If the patient gives any history, bitter taste, or foul smelling, you said undigested food particles, you are committed.
Yes, sir. Yes, sir.
So what do you think it is, with all these things? As you said, Sir rightly pointed out, every condition has to be listed out separately. It is inflammatory, or it is benign, or whatever it is. So
Yes.
what do you think it is? All these things put together.
Sir, most likely with the given history and condition, it seems like to be a condition of the pancreas. Sir.
Radiating to the back.
Radiating to the back.
That is the only history, is a non-alcoholic. These
Yes,
are
sir.
these are
Non-alcoholic.
ones. So you mentioned 90 ml per day.
Yes, sir.
Then after that, last binge was about 3 years back.
Yes, sir. He started his first attack 3 years back.
So after 3 years, why is getting all these symptoms now? How do you explain that?
Sir, so he had the first episode was 3 years back, and then after which he has been having recurrent attacks of pancreatitis.
But he has abstained alcohol since 3 years, you have written.
So that is what he's saying is.
That's what he is saying. So maybe true or may not be true. That's okay. So it is
Yes.
Sir, can I interrupt?
Please, sir.
Please, sir.
You have said 4 admissions in these last 10 years or so.
3 years, yes.
3 years. So why don't you say something more about those admissions? Did it last for more than a week, or was it just 1 or 2 days of admissions? And what is the importance?
Sir, so it will patient has history of over the last 3 years 4 admissions are there. Last 2 admissions have been at our center, sir. Previous 2 admissions were at a private hospital where he was managed conservatively and endured for less than a week, sir. He did not have the papers for the same.
What about
But
the first admission? Because generally in pancreatitis, when it comes and goes,
yes, sir.
it could be relapsing acute pancreatitis, or it could even be pseudocyst. A complication has already set in. And if a pseudocyst has occurred, then the predisposing thing should be, it should have been acute severe pancreatitis, or it may have been a trauma-induced pancreatitis. So that's why the duration of hospital stay, whether patient was in the ICU, all these things become important.
Sir, he has had no hospital admission till date, sir.
No, what do you think? The vomiting is because of direct pancreatitis or because of some obstruction of the stomach because of some compression?
He has had vomiting even previously, which was most likely secondary to the pancreatitis that he had. But over the last 10 days that he is saying it has increased, seems most likely because of the pressure symptoms that is being caused by the collection.
Some collection. Could be an
Yes.
acute fluid collection or a pseudopancreatic cyst.
Acute, yes.
Okay.
Yeah, Dr. Vayama, this patient has been admitted to your center,
Yes, sir.
right? So you must be having an idea about him,
Yes, sir.
right? So you can mention that in your history. There's no harm in doing that, right? You can't just you have some knowledge about it, but you can't keep it hidden. You have to tell us, right? You can tell us that he was admitted for pancreatitis or whatever, right?
Okay, sir. He was admitted
So
for
what's the
pancreatitis.
pancreatitis, right?
Yes.
So okay, so what's the differential now? You know, you probably have the diagnosis, but look, what could be the differential? Let's come to that.
My first most likely diagnosis could be a pseudocyst of the pancreas. Other differential diagnosis, less likely, but can be possible, can be, sir, other cystic neoplasms of the pancreas.
Cystic neoplasm of the pancreas. Okay. Right. What else?
Now, will cystic neoplasms be causing symptoms like this?
This kind.
On and
Yeah,
off
they will
pain?
not. They're not very large. Right.
Not
If they're so large.
You said
Yes, sir.
moderately severe intensity pain. So that generally doesn't occur with
Cystic
this
neoplasm.
cystic neoplasm. Unless it occurs and it increases in front of you, not like it just comes and goes. That is only for pseudocyst.
intermittent history, yes.
Okay. Dr. Vyama, I think you should broaden your thought and think about what are the other structures which would be causing this kind of a issue. Can it be gastric outlet obstruction?
So
Right.
can gastric outlet obstruction, yes, sir.
Okay, so you have to think about that. Can it be anything to do with the lower esophagus?
Lower esophagus, yes, sir, but less likely to have any
Okay.
mass formation. Lump less
Right.
likely to have, sir.
Okay, so gastric outlet obstruction could be producing this
Yes.
kind of a dilated stomach with vomiting.
Yes, sir.
Right.
But patient complaining of pain, so that is why.
What
Okay.
will be the reason for the pseudocyst producing gastric outlet obstruction? How do you explain that? The mechanism.
So it is because of compression causing
Compression where?
Can it be anything else? Can it be just compression or anything else? Can
See, the
it
patient also
in
has
acute
history of,
cases?
yeah,
Sorry, please.
the patient has history of tuberculosis also, as you said.
Yes, sir.
So could it be something, complication of tuberculosis of the abdomen as well?
So tubercular peritonitis can have omental caking and that can cause a lump to be formed maybe. But patient may also have, sir, some other symptoms of maybe rise of fever or loss of appetite or any maybe cause of obstruction or something, features of subacute obstruction at least. Sir, if patient had abdominal cocks with such lump formations.
But will the patient come with pain abdomen? In
Sir, if
tuberculosis?
peritonitis, if settled in then.
No, the patient doesn't have fever.
Yes, sir. No.
Okay.
Less likely to be abdominal cocks, sir.
So will we go to the examination part also now?
Yeah.
No,
So,
before,
so Vyama,
Yes,
Vyama,
Can
like
I
sir
ask
said,
some question?
please, sir.
Yes. See, Dr. Voyama, usually the be always prospective as well as retrospective. I agree. But if we go prospectively, saying this history, did you ask whether there is any history of early satiety? There is a history of ball rolling movement, because these are upper abdominal symptoms where, as sir said, probably it may be a gastric outlet obstruction. And there are various causes for the gastric outlet obstruction. So considering that you should rule out all the causes for the gastric outlet obstruction, probably your examination finding and past history of multiple admissions with acute pancreatitis may go towards the pseudocyst of the pancreas. However, if you go with that diagnosis and put your history to fix that, should not happen. So you should rule out all the causes of gastric outlet obstruction, what I feel. You should rule out the acid peptic disease, even the malignancy of the stomach. So this you should keep in always mind. Your view in the history should be quite broad. And with clinical examination, it should slowly, it should focus towards the diagnosis. You should keep in mind.
Dr. Mehta,
Yes.
in PG exam, there is no marks for your diagnosis. There is marks for differential diagnosis. How you are excluding differential diagnosis, that is more important. That's why negative history is very important. And there you can score the marks also. Okay, thank you.
Dalvi sir
Okay,
wanted to ask something?
yeah, please. Okay, let's move to the examination zone over there.
No,
Vayama
I
examination.
just asked one question.
Please.
Let the candidate enumerate causes of chronic gastric outlet obstruction, since she has said that it's a non-bilious vomit.
Okay, Vayama, answer sir's question.
Sir, pyloric stenosis, CA or CA stomach, carcinoma of the stomach can cause gastric outlet obstruction.
What are the non-malignant conditions where patient vomits non-bilious vomit? Can you answer this, please? Patient comes to you complaining of a chronic non-bilious vomit. What are the things that come to your mind?
Gastroesophageal reflux disease come first.
Reflux disease. Okay. You have to remember one thing, that in the history, there has to be pyloric obstruction for a non-bilious vomit. You are taking it too far. GRD. Okay. What else?
That is retching, not vomiting.
Yeah.
Gently.
No, but let us give her some time to think.
Yes.
Okay, my second question to you is, what are the acute, subacute, and chronic
Condition.
symptoms of duodenal ulcer obstructions, duodenal complications?
So acute complication can be perforation
Yes.
Good.
and bleeding, sir.
Okay, very nice.
So then later on, so stricture formation can be there. Stricture formation leading to obstruction.
Correct. That is chronic obstruction.
Chronic obstruction.
Now
yeah.
tell me subacute.
Subacute.
If you have read Bailey Love, you will know it. Otherwise, no. Say no.
I don't know.
Okay. I'm just taking you away from your diagnosis. Just tell me, how do you treat bleeding from a duodenal ulcer?
So clip.
Quickly say yes or no and forget.
No, sir. I don't know. Sir.
Okay. So you have to go and read. Okay. I'll leave it to the other examiners. Thank you.
Vayama, I'll just help you out in answering sir's question. Think, anyone who's bleeding, what do you have to do first?
So
You give
scopy,
fluids.
do an endoscopy. And,
No. You have to save the patient first.
Yes,
You have
sir.
to stabilize the patient. So you give
Hemodynamic.
oxygen, you give fluids, you cross match for blood. You if this duodenal ulcer, you give pantoprazole. So you just say this.
Yes, sir.
Right?
So we start
If
the
you
patient
save
on a drip.
these few things, Professor Dalvi will be satisfied and say, "Ah, she knows," and he'll move away. Right? But so think, don't just give up in one instance. Your job as a surgeon is to manage the patient in acute case. Save the patient, resuscitate him. Okay.
So in
Should
that,
we go to the examination? Yeah, please. Examination.
the patient is examined in a well-lit room with adequate exposure and due consent. Patient is conscious, cooperative, and oriented to time-place person. He's lying comfortably on the bed, averagely built and fairly nourished, with a BMI of 19.6. So patient's vitals, pulse was 92 per minute regular, BP 110 by 70 millimeters of mercury in the right brachial artery in sitting position. Saturation was 98% on room air, and respiratory rate was 16 per minute. Patient does not have pallor, icterus, clubbing, or cyanosis, or any lymphadenopathy. No stigmata of liver disease is present. No supraclavicular fullness or lump was present. External genitalia and scrotum is normal. Systemic examination. So for abdominal, on inspection, patient has abdominal fullness in the left hypochondriac and epigastric region.
Dr. Vyam, I'll just stop you here.
Yes.
It's not hypochondriac. You said in there also,
Yes.
here also, right?
Yes.
Don't these kind of small mistakes puts the examiners off, right? Go on, please.
Umbilicus is inverted and in the midline it is not displaced. All the quadrants move with respiration. There are no visible scars, sinuses, or dilated veins. There is no visible peristalsis or pulsation seen, and the hernial orifices are intact. No any swelling. On palpation, the abdomen is soft, non-tender, with a singular lump in the epigastrium and left hypochondrium region, reaching the umbilicus, of size approximately 15 by 10 centimeters, with well-defined margins and a smooth surface. The fingers could not be insinuated between the costal margin and the lump. I was unable to go above the lump. On leg raising and head raising, the lump becomes less prominent and the lump does not fall forwards or on the lateral decubitus position. There is no organomegaly seen.
Dr. Mehta,
Yes.
in your inspection and palpation of the lump in abdomen, what
Yes.
are the missing points you are not included in this order of examination? What are different points in order of examination in case of inspection of the lump in abdomen and palpation of the lump in abdomen?
Skin is in inspections or skin. I should
Rather
have
than skin. You have not mentioned about left supraclavicular area, spine, renal angle, genitalia.
Sir,
All these
No,
points
she
are
has.
included in the order of examination.
Yes.
This is very important. All these 4 points are included in the order of examination.
You have not talked about whether the lump moves with respiration or not.
So it doesn't move. No, sir.
So, sir, could we let her finish the examination, then
Yeah.
ask the questions? Yeah, Dr. Verma, please. Go on,
Sir,
please.
Okay. Sir. On percussion, so there's a dull note over the lump with resonant note over the area. Hepatic dullness is noted in the right midclavicular line from the 5th intercostal space, liver span measuring 11 centimeters. There is no free fluid in the abdomen. On auscultation, bowel sounds are present. On digital rectal examination, so no any significant finding present. Sir, external genitalia is normal. Spine is also normal. Renal angle fullness not seen, normal. Cardiovascular systems are heart sounds present, no murmur. Central nervous systems are conscious and patient is oriented to time, place, person. Higher mental status functions also normal. Respiratory systems or air entry was bilaterally equal. So summary. So should I go back to the examination or continue?
Yeah, please go on, finish.
Okay. My patient, 40-year-old gentleman, chronic alcoholic, presented with complaints of severe pain in the epigastrium and the left hypochondrium region with multiple episodes of nausea and non-bilious vomiting over the last 3 years, aggravated over the last 10 days, and has a history of fullness of the upper abdomen since the last 20 days. On examination, he has a 15 by 10 centimeter firm cystic retroperitoneal lump in the epigastrium and the left hypochondrium region with well-defined margins, a smooth surface, and a dull note over the lump. Findings are likely suggestive of pseudocyst of pancreas. So other differentials could be cystic neoplasms of the pancreas.
See, anyone, please.
So you said the history of pain abdomen is since last 10 days, isn't it?
Severe pain, yes, sir. Now.
Severe pain is since last 10 days, and you had fullness of abdomen since before that.
First note, yes, sir, 20 days. Yes.
Okay. So why did you say pseudocyst of pancreas and why not an acute fluid collection? When will you say it to be a pseudocyst?
Sir, I said pseudocyst because he has had previous episodes also, for which his last episode was 2 months back. And then he developed fullness, which he first noticed 20 days back. And then most likely he had another attack, which was last 10 days back. So that was, sir, my understanding. Because if it was a acute fluid collection, then his symptoms of pain would have developed previously.
So how much minimum time do you require for a pseudocyst to call it a pseudocyst?
So 4 weeks.
4 to 6 weeks.
4 to 6 weeks.
Okay.
Okay, let's go to your next slide for examination. Okay, next slide. Okay, Dr. Vayama, it's better if you run a spell check when you present, okay?
Yes.
Genitalia and all. There's a lot of spelling mistakes here. So be more careful. It just shows how attentive a surgeon you are, right?
Yes.
Yeah, next slide, please. So there's fullness there, because okay, on his all quadrants moving equally with respiration should be put. Quadrants, all quadrants are moving relatively relative to each other, right? All quadrants are moving to respiration relative to each other because the lower abdomen will not move as much as the upper abdomen. Okay.
Yes.
Right. Next slide, please. Now, do you have the inspection of the lump? You just have inspection of the abdomen. Other than fullness, just go back, please. There's just written fullness from this side. Is it pulsatile? No. Is it pulsatile? Is there cuff impulse there? Right?
Yes.
All that, everything about it. Is it smooth in surface?
Yes, moving with respiration.
Is it moving with respiration? All that has to come, right? Inspection. Okay. Right. Next slide. Okay. Is the temperature raised? No. Tender, well-defined, smooth surface.
Yes, sir. No,
are all the margins palpable?
Sir, except the superior, yes. Superior is not.
So that has to be mentioned.
So I couldn't go above the swelling. So written fingers could not fit between
because there's an importance for that, nah? So just you should mention that.
Yes.
Okay.
Sir, I think she mentioned that the upper border cannot be felt.
Felt, yes, sir. Again, by palpation, you have to say whether it is moving or not. Maybe by inspection, you could not make out. Even on palpation, you can at least ascertain whether it is like some movement is there or not. That you have to commit. Okay, all the borders are felt. Superior border, you are not able to insinuate. Okay.
Why is this moving with respiration important?
Sir, so it can help us with going to the organ that is that we are palpating. So if it is
you don't have sorry, go on, please.
What about the consistency?
So consistency, sir, it is firm.
No, you said cystic, no?
You said cystic. It is uniformly cystic.
Cystic, yes.
No, you already committed. You can't change now.
It is.
No, one is that. Second, how do you know it is cystic in an intra-abdominal swelling? Is it easy to say that?
That is important.
And did you do an ausculto percussion to see for the size of the stomach?
So should we go one by one, sir?
Yes,
right. Moving with respiration tells you straight away that it is not an intraperitoneal lump. Okay. About cystic, intra-abdominal or retroperitoneal lumps, you cannot say whether it's cystic because you've got the stomach over it. You can't. Right. What was the third question, Dr. Das, which you asked?
For stomach.
Yeah.
Sir, Rajiv sir, it's you also have the abdominal wall in front, so that also hinders your palpating for whether it is cystic and not
Yeah, you
there.
can't. You can never commit yourself like that. Okay.
Okay.
Right. So next slide, please.
Another thing, one thing is, does it really confine itself to the epigastrium or does it extend to the lumbar? Is
Sir,
it
no,
lateral to
not,
midclavicular? Is it lateral to midclavicular line?
sir, on the left, yes, not on the right. Sir.
No, I'm saying left only.
Yes, sir.
So
It
what
is
is that? What is that line? The space called that region of the abdomen called?
to the
You have
left.
9 regions, no? 9 region lumbar. What is the boundaries of the lumbar region on the left side?
On the left side, it is the left mid-clavicular line and between the intertubercle and the transpyloric line, sir. Yes.
That's all. Transpyloric. Where is the transpyloric here in this? The swelling is below the transpyloric, isn't it? It's almost
Yes,
near the umbilicus.
yes, sir.
So, and if it is lateral to extending lateral to midclavicular, obviously lumbar is also involved.
Involving lumbar also.
You're
Yes.
repeatedly saying hypochondriac, like Raju sir was saying. The
So
common
it would be
mistake.
safer if you said left upper quadrant.
Left upper quadrant. Okay.
Right? Now,
Yeah.
can it be a hydronephrotic kidney?
Sir, renal angle was normal and it's not bilateral. And patient also does not have any other complaints related.
Okay. Next slide, please. Let's because running short of time. Percussion dull note over the lump with resonant. Why should there be a dull note over the lump if it's a retroperitoneal behind the stomach?
Sir, only in the just below the xiphisternum area there is a resonant note. Otherwise, sir, it is a dull note, sir. Everywhere else.
Does that tell you anything? What
Sir,
information do you get by that?
sir, that it is just below the anterior abdominal wall, sir. The lump.
No,
So,
what sir is
so
asking is it behind the stomach or it is below the stomach? That's the question. You understand
Yes,
that?
it has come below. It has now. It is below the stomach, sir.
Yeah, otherwise you get the fluid in the stomach.
Resonant note.
Yeah.
Yes.
That means your swelling goes up to the upper costal margin. How can the stomach has gone intrathoracic?
Sir, so mostly it is shifted, sir, to
No,
right.
the very
From present.
first question is asked. How do you say it is lump is dull on note? That means there is no anteriorly, there is no stomach. It is not posterior to the stomach. If you say that is below the stomach, that means the stomach must have gone to the thorax.
I'll just say bail you out, Dr. Vayama. What happens if you write such a thing like it doesn't convey any message, and you're digging a grave for yourself, right? So just let it go. If someone asks you about percussion of the thing, then you say, that's a smart way of putting it.
What
So
is
another
top space?
explanation, Jalal sir,
Yes.
is that since she says that the stomach is obstructed, there is a mass and all that. So it could be that the some collection somewhere in the body or neck of pancreas is causing a distension of the stomach, and stomach is full with fluid.
So she has other GOO is also there additionally.
Yeah, because we do not know what the mass is, whether it's a distended stomach or it's actually pseudocyst involving the left half. We are not sure until now, as far as the findings are there.
No, yeah, fine. But she has to explain why is she saying that.
Yeah.
So
What is
his
the drop space?
drop
So
space.
that is where the auscultopercussion comes. That is what I asked, whether you have done an auscultopercussion to see for the size of the stomach. So if the size of the stomach is small, that means it's something else. If you're getting this, the whole thing that you have drawn in the picture, it could be a stomach as well. Dilated stomach.
Yeah, definitely.
He says history-wise, he says non-bilious vomiting, sir. That
Yeah,
means
that also goes in favor of stomach now, sir.
stomach only. That means obstruction is distal and it is almost total obstruction.
Okay, Dr.
But
Vayama,
here
let's go to
the
your.
mass looks like a retroperitoneal mass. No, how it can be a stomach? How can we put diagnosis as a stomach mass?
Dr. Vayama, let's go to your last slide, please. Dr. Vayama, are you there?
Yes, sir.
Yeah, let's go to your last slide.
Yes.
Okay.
Uh,
So, how do you proceed now?
so we would like to go ahead with investigations for the patient. We start with laboratory investigations, and all our should be sent a CBC, RFT, LFT. We should also send amylase
Vayama,
for the
please
Vayama.
yes,
check if you are mentioning with so much of large mass and saying it is only in the epigastrium and hypochondrium. Absolutely, it is not an acceptable one. Hypochondrium and epigastrium is a very small space. You can't have a large mass coming up to the umbilicus, and in the summer you are saying the swelling is only confined to that region. That means you are not particular about the anatomy we are talking about that. Okay, go ahead.
Okay. Right. So you, like we said, you should say right upper quadrant or right lower quadrant or upper half of the abdomen. Dr. Vayama, are you there? I think you're stuck.
yes, sir. Yes, sir.
Yeah. Okay. So look,
No,
blood tests are fine. Your first answer should be get an ultrasound done, which is an extension of
yes,
your clinical examination.
yes, sir.
Okay. So do you have the ultrasound report with you?
Yes, sir.
Okay. Can you put it up?
So I did not attach.
Okay. Tell us. If you remember, tell us.
Sir, so patient has a collection of approximately 12 into 16 into 9 centimeters in the pancreas, suggestive of. So 1 second, I will.
If it is a pseudopancreatic cyst, where is the collection normally?
Sir, in the lesser sac, sir,
Lesser sac, isn't it? They will say behind the stomach.
behind the stomach.
Starting from behind the stomach, it can go up to the downwards also retroperitoneally.
Yes, sir.
Okay.
And so,
Okay. So next ultrasound. Then what?
What?
so after on ultrasound, we'll also see for other features of the pore, vessels also we'll see. And sir, then we'll proceed. If it has been more than 72 hours, we'll go with the CT scan, sir.
No.
CC.
Hang
No,
on,
no,
Doctor.
CT scan
Dr.
doesn't come
Vayama.
now. No.
No, you can't do just CT scan straight away. I mean, why what way why you don't get a CT scan just
Sir, to look for
72 hours of what?
after
Why are you waiting for say?
so for acute, in cases of acute pancreatitis, if patient
So
has
you
come,
think he's in acute cases now? He's in acute now.
so one episode that started 10 days back.
So any test that you can do and confirm whether the patient is having acute pancreatitis or not.
Yes, sir, lipase on that.
So get the amylase and the lipase done.
Yeah.
Yes.
So pain
So
for
before
pregnant.
CT, we'll have to do these investigations. Okay.
Yes, sir.
Right. Now tell us what investigations will you do?
I think Abhay sir has raised his hand. Sir, please, you can join anytime, sir.
I just want to ask this candidate, what is stomach bed?
Sir, the stomach bed will have pancreas, the renal, the spleen, and the adrenal.
Come again, come again.
So the body of pancreas and tail. Sir, the left.
Tell me anatomical, anterior, superior, posterior, inferior, and lateral. See, you are defining pseudocyst as a collection behind the stomach, right? It happens in the lesser sac. That is what you said. So there is something known as anatomically stomach bed. So I just want to know whether you know what is stomach bed. And then how this pseudocyst, so-called pseudocyst, you have still not you are saying you don't know Atlanta classification. I don't want to get into it, but how does it percolate into paracolic, etc., etc.? Do you know how it goes about? Quickly say I don't know and get away.
Sorry, sir.
It's okay. Others can take over, please.
Okay, Vayaman, let's go with the investigations. What are the investigations, important investigations now?
So we do an ultrasound and then we'll go ahead with the CT scan. Or sir, before that,
Give us the blood. Vayama, why are you hurrying with the CT scan? What do you want to do? You want to intervene just now? Then?
so we start with blood investigations, then we go ahead with the USG.
Right. Yeah, go on. Tell us what are the important blood tests you would like to do.
So we'll start with the CBC, the renal function test, the liver function test, the amylase and lipase of the patient.
Why CBC? What are you looking for in CBC now?
So to look for any
what are the red flags things in CBC?
HB,
is it bleeding?
Patient
is
does
it
not,
bleeding?
No, sir.
Is the patient bleeding? So you look at the hemoglobin. Is it infected? You look at the total count, right? Is the patient dehydrated? You look at the PCV, right? Okay. Next investigation.
So for
what is the blood sugar of the patient?
Blood sugars
has the patient become diabetic recently?
No, sir.
So you get the RBS done.
RBS and HbA1c.
Now you get, what about LFT, KFT? What about LFT? What about KFT? What are the red flag signs there?
So RFT patient can have dehydration, also can have AKI induced. So creatinine should be looked for and electrolytes also, because patient has vomiting history. So electrolytes can be deranged.
In pancreatitis, calcium is very important.
Calcium, yes.
Right?
Yes.
Isn't it? Okay. What about amylase lipase?
Amylase lipase.
Right. Any other investigations? Tumor markers?
So tumor markers, CEA and CA99 can be sent if we are suspecting anemia.
And we know you have to do it. You have a differential of neoplastic cysts.
Neoplastic, CA and CA99.
What is your diagnosis? You have said it's a pseudocyst, no?
Yes, sir.
Okay, do you now, going back, you have already done an ultrasound. Your history, is it to correspond with that pseudocyst? Because you said the only 20 days symptoms, 10 days the pain.
Yes, sir.
Do you still call it as a pseudocyst if there is a 10 days or 20 days before you suspect a pancreatitis? No, you say one way your clinical diagnosis, but now, so your diagnosis, I think you have made only based on the ultrasonogram, not on your clinical findings. The examination,
Okay,
what
tell
we are
sir again, why did you come to a diagnosis of pseudocyst?
You clinically, you must correlate your finding. That is the most important thing in the examination.
Right.
Okay, now go ahead with that, your management.
Now you can say you can't see her. She gone out of coverage.
No, sir.
No, she's there.
Yes,
she's there, very much there.
So you can say that there has been 4 admissions. It has been there for 3 years, and therefore you are suspecting that a complication of pseudocyst has occurred. That's how you answer.
Yes, sir.
Okay, go on now. Next.
Yeah, the question comes where whether the leukocytosis is there, and if it is there, whether the lactate is high.
What is your plan?
Sir, in this patient, we will first see if the wall, if patient currently it does not have any infected complaints or anything.
No, sir is very categorically asking. The infection is there. Where their lactate is also high. Leukocytosis.
So then we will do a percutaneous drainage should be advised for the patient, sir. If infected
No, sir, I didn't say that. I was just asking whether you should be doing a leukocytosis test, to find total count, to find out if there is an infected component. And if it is high, then look for lactate, not that it is infected already.
Okay.
Just that you must know that, because you are going away from blood count to CT scan straight away.
Sir,
And
can I
Vayama-
come in? Can I come in
Sir,
here?
Please, sir.
Yeah, the candidate should ask. I want to ask the candidate, when you ask for a CT scan in a so-called pseudocyst, which I don't agree, what are the things that you are going to look for, or ask the radiologist to give you information?
Sir, the size, the wall thickness, sir, the distance from the stomach wall. And
What else? What else?
the
What are the things that happen in acute pancreatitis leading to peripancreatic collection? So many things can happen. What do you want to know if you want to think of intervention?
Yes, sir. Sir, also to look at the vessels. If
Which
there is
vessels? You got to name properly, ma'am.
the splenic artery or the GDA, if the gastroduodenal artery. So
Why? Why?
Because there can be formation of a pseudoaneurysm there, or if
Pseudoaneurysm in the splenic artery.
Vayama, please don't go all over just like this. This is a pseudocyst. We want to know whether there's a connection between the pancreatic duct and the cyst, right?
Yes.
If you have infection and you do an external drainage, you're gonna form a pancreatic fistula if there's a connection. So the most important thing in CT is that you find out whether there is collection, what is the size, what is the site, what is the thickness, what is the distance from the wall.
Yes, sir.
Right? These are the things which you have to look for.
And for the connection, is the CT better or an MRI better?
Sir, MRCP will give us a better idea about the duct connections.
No. MRI is better for cystic pancreatic malignancies. Pancreatic cystic malignancies. Here, CT scan is better. MRI will not tell you this. Don't do that. Yeah, go on. So, this is what you look in CT. What are the investigations? Okay, we've done with the investigations. Now, what do you do? Do you have the CT report with you?
Endo ultrasonogram?
Sorry, sir.
Yeah, exactly. What about endoscopic ultrasound?
And EUS, sir, it can help with diagnosis and therapeutically also. So if we will do an EUS to see the wall thickness and if the distance between the stomach wall and the cyst. So
Dr. Vayama, if you don't get it on endoscopic ultrasound is a minimally invasive, isn't it?
Yes.
If you will continue, you'll do that if you suspect something in the stomach, the pylorus, and if your CT is not quite conclusive, right? You can get all this information by CT.
Yes.
Unless you suspect.
Yeah. What additional information you get on endoscopic ultrasound
Right.
over
Now
what you
tell
get
us
on
that.
a CT? You can aspirate something and get some idea.
Fluid analysis can be sent. Any intervention can be done.
No. What analysis of the fluid you do?
Sir, fluid analysis for one we'll send for culture, sir. We will send for CEA. We will send for mucin.
Vayama, please. What is the first thing? Culture. What are you going to get by culture? What are you looking for in culture in a cyst of the pancreas? Why do you do this? Because you have to rule out malignancy.
Yeah. The problem is you didn't mention amylase.
Amylase, sir.
Yeah, you must say amylase and then go on. Yeah.
And if you want to look for amylase, you can, it's such a large lump, you can go from the skin and do it, isn't it? So EUS is not indicated here until unless you suspect it's a small cyst with you suspect malignancy. Okay. Now tell us, how will you proceed?
Sir,
Everything's done, CT is done. What will you do now? What are the indications for surgery?
Indications for surgery, sir. If patient has symptoms of of gastric outlet obstruction if patient is having, or if there is any the thickness of the wall has matured more than 6.
Vayama, please hang on. If the symptoms worsen or don't settle on your conservative management, one, what else? What else? Now come to that. What are the symptoms? Vomiting, pain, all that kind of thing, which is admitted for. What else?
This larger than 6 centimeters, so most likely will require.
This is how much? 10, 12 centimeters.
Yes, sir.
Will you go in for surgery straight away?
So we can first do endoscopic cystogastrostomy.
No, why? You said when the thing is more than 6 centimeters. This is almost 15 centimeters.
To resolve then, so then will require intervention, sir.
Please come again.
So less likely to resolve on its own, so patient will require intervention if it is more than 6 centimeters.
Right. So you have to give it time to resolve. If it doesn't resolve, then you go in. Right. So you just can't say because it's 15 centimeters, the patient is not having any symptoms. You will go in. You will not. Right. Okay. What are the other conditions and the other indications for surgery?
So if there is any bleeding or
very good. So if there is any hemorrhage, pseudoaneurysms which rupture, what else? We all discussed that if there is infection.
Infection, yes, sir. So then
right. Okay. So okay. What kind of intervention will you do?
So endoscopic cystogastrostomy should be planned according to the location.
What are the indications for cystogastrostomy? What are the indications for cystoduodenostomy? And what are the systems indications for Roux-en-Y?
So location of the collection. So pseudocyst can be in the lesser sac, or it can be retrogastric or retroduodenal also. So according to the location, then we will do the drainage procedure.
No, okay. In this patient, what are the, like I asked you, what are the indications of cystogastrostomy? What is the prerequisite condition? Okay, let's come to that. What is the prerequisite condition for doing a cystogastrostomy?
So the distance should be less than 1 centimeter between the wall of the stomach wall and the cyst wall. So.
Right. That is the most important.
Proximity.
Now what?
Very near the gastric wall. That is one thing. And remember, Sir is leading you, guiding you, literally holding hand and taking you.
Yeah.
Thickness, the
so
pseudocyst thickness. How much thickness is necessary to do intervention?
So 6 mm they say, but at 4 mm also we can do intervention.
Not 4 mm.
4 mm, 6 mm. This is you can't say at 4 mm I can also do. You can do it even at 2 mm. So what? Why don't you do it?
6 mm.
Why is it 6 mm?
Sir,
why do you need a 6 mm?
So otherwise it will not hold. The sutures will not hold and it will tear off and there will be leakage. So it is not mature enough.
Where are you going to put the sutures?
Sorry, sir.
Where do you put the suture? Where do you suture in cystogastrostomy?
So we open the anterior wall of the
at the posterior wall and the cyst.
Yes, sir.
So what has 2 mm got to do with it? You can still put it using the stomach wall, which is thick enough. You can still stitch it. 2 mm is that because if you have to clean the inside, or when you do it, it can just rupture. It can bleed. It will not be organized. Do you get me? That's why.
So whenever you tell me for this patient, what are the other options that you have for treatment? You said endoscopic option, isn't it? Number 1.
Yes, sir.
And?
So surgical cystogastrostomy.
Any other endoscopic? Suppose it is communicating with the duct.
So then we'll do stenting for the patient if there is communication.
Right. Yeah. So you just can't go in for a cystogastrostomy straight away. If it is communicating, you do an endoscopy. Anything else? Okay, what cystoduodenostomy? What is the indication for that? If your cyst is close to the duodenum, so cysts in the head or the uncinate process. You get me?
The anatomical
Okay, what?
abutting which organ is very near. Based on that, we do the drainage. We have
Number
excellent,
Okay, what
excellent
about
imaging.
Roux-en-Y?
What is Rowan?
Right.
Yes.
What about Roux-en-Y?
Sorry.
So any type of pseudocyst, you can do a Roux-en-Y. Any type,
Okay, sir.
unless
Respected
it's
teachers,
small and just lying behind the stomach. Okay,
Rajiv sir,
sir,
sir, we have one more student. Can we finish in 5
yeah,
minutes?
please.
I think
Sir, anyone else? I
Thyroid,
think,
yeah,
please,
yes, sir.
sir,
Anyone?
sir, please, anyone else? Okay, just last question, Vayama. When will a cyst not resolve?
So larger cysts will not resolve if
No, there's nothing called larger. Size is not a criteria. Please. You've seen large cysts also resolves.
so chronic pancreatitis normally cysts do not resolve.
Right. So if the amylase keeps persistingly high, right?
Yes.
Second,
So
They continue to have symptoms or a complication develops.
they will not resolve, right? If it is more than 6 weeks and still not, there's no change in spite of your treatment. If there is increase in size, right? Or there's persistent pancreatic duct connection.
connection.
These are the
It is called
indications.
pseudocyst. Why not cyst?
Yeah. Basic question. Why
So-
a pseudocyst?
So it does not have a true wall lining. That is granulation tissue and
What lining are you looking for to call it a cyst?
epithelial lining. So it does not have an
Very good.
So how when you are
Okay.
anastomosing, then whether the content of the cyst will come into the stomach when you are eating will it go to the stomach? The cyst wall?
No, so it does not
Okay.
go.
Why?
So exact mechanism is not known, but mostly it is because of the gravity, one, and two, sir, the pressure that comes with it. So it goes further down.
No,
So
no,
they-
it is because of the ball valve mechanism. Okay, the cyst will become small and then it will come and stuck up.
collapses. The cyst collapses.
It collapses, it comes up.
Right?
You in the first post-operative day, you are going to the rounds. It is profusely bleeding. You are
Yeah,
done
what
a
do you do?
cystectomy.
Patient has melena or
Or melena.
hematochezis.
Patient is having melena. What do you suspect and how do you manage?
Sir, could be a bleed from the wall that we have sutured. Second, it can be bleeding from the vessel if any suture has come through it.
So how do you manage that?
Sir, first stabilize the patient, give fluids, and if required, inotropes if patient has required, and blood is to be given, cross match and give blood.
All that you have done.
Okay, sir.
Specific management.
Sorry, sir.
Specific
Specific
what are the
management.
approaches you can use?
Sir, if surgery has been done, then a re-surgery to be done, or if scopy got it, then we will do a scopy.
Radiologist can help it.
Interventional radiology, sir, if it
Right.
is, can be done embolization if it is
Very
via
good.
a vessel.
Very good. That's what we're
All
looking for.
this you should see. It's not surgery immediately. You can do the endoscopy, find out, embolization, find out.
Yeah, nowadays I think it's interventional radiology. Only if it
Right.
fails or it is not feasible, will you look for it. Doing a surgery second time after pancreatic surgery, do you think it is quite simple?
No, sir.
You'll curse the day you're born, become a surgeon. Curse the day you became a surgeon. Right? Don't do it.
Okay.
Okay, Vayama, well done. You go and read about pseudocysts, okay?
Yes, sir.
Today, go and hog up on pseudocyst, everything about it.
Basically, the indications for surgery, that you're not very clear. So go back and read that.
Indications for surgery. When do you, what kind of surgeries do you do? What are the complications, right? How do you diagnose? How do you manage? Right? All that kind of thing. Well done. Otherwise, well done. What is more important that your history and examination was quite okay? Right. Any questions for your examiners?
No, sir. No, sir.
That's
No,
all.
no.
Yeah.
So could
Did
you all
well,
just
man.
give her a feedback? So
I
could
am
you all
did
give
well.
her a feedback, please?
Yes, sir. So it
Thank
is
you. Do you have any questions to be clarified, ma'am?
no, sir.
Professor Jayal, I'll give her a feedback, please.
No, it is fine. When she has letter part management side, she is written. That shows that she is working in the ward. But little more in the examination, we on the clinical examination and your correlation. And why do you come to that conclusion? It should be based on your clinical, than on your otherwise. This case, there is not much of examination. Only thing when you say the where it is situated, how much is the percussion, all these findings are little important. Otherwise, I couldn't understand that you have worked in the ward, you have seen cases, you are operating, you are helping. So that way it is good.
Thank you.
Dr. Das, Professor Das, anything for her?
No, she's fine. I
Nice
think she's good.
presentation.
Yeah, nice presentation.
Thank you very much, Priyama. In spite of having a difficult situation, you could join. Dr. Shilpa just now called me and told about your NMC inspection, your phone, and all other things. So, wish all these things are resolved. And thank you for joining this. And I thank Dr. Shilpa Rao ma'am also for permitting you for joining this afternoon.
Thank you, sir.
Thank you. You did well.
Well done, dear.
Well
Well
done.
done,
Well
Dr.
done.
Presentation, ma'am.
Now,
Everything is set?
yes, sir. Am
And
I audible now?
Yes.
so she'll be presenting a case of neck swelling, of course, a thyroid swelling. I request the faculty to kindly take over. Good luck to you, Dr. Geetu. Sir, Babu sir and Thomas sir are here with us, right, sir?
Yes, sir. The
Okay.
PT sir is with us. Yes.
Okay, sir, please, I request you also to comment or give any suggestions if the candidate is finding difficult, sir. Thank you very much. Faculty, kindly take over.
Yes.
Good luck to you, Dr. Geetu. Please introduce yourself, your unit chief, head of the department, and start your presentation.
Thank you, sir. I'm Dr. Goitre Suresh, junior resident from Department of General Surgery. My head of the department is Dr. Sunil S. and my unit chief is Dr. Robinson George. Can I start my presentation, sir?
Please.
My patient, Mrs. X, 76-year-old female, who is a housewife hailing from Tiruvalla, Kerala, with chief complaint swelling in front of the neck for 10 years and difficulty in breathing since the past 3 months. History of present illness. 76-year-old female presented with swelling in front extending to sides of neck since the past 10 years. Initially, the swelling was 1 finger breadth in size near the lower neck on the right side above the clavicle. Gradually, it progressed to attain the present size of 1 palmar width, extending to either sides and more prominent on the right side. There was no history of rapid increase in size or no history of pain in the swelling. She also has associated breathing difficulty since the last 3 months. It was insidious in onset, present throughout the day following exertion. It was aggravated on lying down in supine as well as in left lateral positions and relieved on right lateral position. There was no history of heat or cold intolerance, no history of difficulty in swallowing or alteration in voice, no history of constipation or diarrhea, no history of weight gain or weight loss. There is no history of palpitation, tremors, irritability, insomnia, or weakness of limbs, and no history of staring look or double vision. Coming to the past history, she is a known case of systemic hypertension since 20 years and is on medication. There was no history of irradiation to head and neck in the childhood and no surgical history in the past. Personal history, she consumes a mixed diet, her appetite is normal, her sleep is normal, and bowel and bladder habits are also normal. Menstrual and reproductive history. She attained menarche at the age of 13. There were no menstrual irregularities, no history of abortions or miscarriages, and menopause attained at the age of 50. Family history. There was no thyroid-related disorders or malignancies in the family. Drug history. She is currently on antihypertensives. Summary. 76-year-old female who is a known case of systemic hypertension, presented with a swelling in front extending to sides of neck of 1 palmar width in size, present since the past 10 years. She also has associated difficulty in breathing since the past 3 months, present throughout the day and aggravated on lying in supine and left lateral position and relieved on right lateral position.
Okay.
You,
Dr. Gita, let's go to your first slide.
Kidu, you said the
Okay.
patient had no difficulty in sleeping, but you said patient in a supine position, she can't lie down. She has an difficulty in breathing. How do you correlate these two?
Her sleep cycles are actually normal, but she has difficulty only when on lying down in the supine position and on left lateral position.
I think people will sleep by lying down only.
Yes, so she has breathing difficulty when on lying down and in the left lateral position.
Please explain somebody who has a breathing difficulty, orthopnea, how he will have a good sleep.
Sir, on the right lateral position, she is relieved. So she always prefers to have.
Be careful in presenting like this. And why do you expect for a thyroid swelling only to have an orthopnea?
Sir, in thyroid swelling, sometimes if there is toxicity in secondary thyroid toxicosis, they can have congestive cardiac failure and can present with.
No. Gitu. We are talking about this patient. Your patient is euthyroid. So why should she have difficulty?
Sir, a long-standing goiter of past 10 years, she can have compressive symptoms and on the trachea that cause luminal narrowing.
That can be there even when she is supine or when she is erect. Both the time it can compress. And okay, go ahead. We'll come to that when
we'll come to that. Okay, let's get your history corrected first. 1 finger breadth in size. Just you can tell us the approximate size. What is 1 finger? Mention it. Is 1 finger breadth? It's about a centimeter. Okay. My finger breadth and your finger breadth could be different, right? So don't do that. Palm width. Whose palm? A newborn's palm, your palm, patient's palm, elephant's palm. Okay. So just mention us the approximate size.
You have next the photo of the patient?
Yes, sir. In examination, I have.
Okay.
Let's
go to your next slide, please.
You said the rapid increase in size. What is the sudden increase size and what is rapid increase in size?
So sudden increase in size, it is suggestive of hemorrhage into swelling.
First,
and
tell us what you mean by sudden and rapid. What's the difference between the two? What's sudden? What is rapid?
So rapid means it takes some months months of increase in size, but sudden increase means it happens within hours or 1 day.
Yeah, you get up in the morning, suddenly it's bloated up.
Okay. So basically, the rapid is for malignancy.
That insidious in onset.
So what are the causes for it?
Pardon, sir?
Insidious.
What are the causes for sudden increase in size?
Sudden increase in size can be due to hemorrhage into a nodule, or it can be because of malignancy.
Sudden decrease in size. Okay.
Sir?
Can't be because
sudden
of malignancy.
Or decrease in size in case of goiter.
Sudden decrease in size. So pardon, sir, I can't hear you.
It is due to necrosis in a pre-existing nodule.
Okay, go ahead. Go ahead.
Okay, there's nothing called insidious in onset. Onset will be, what do you mean? It's coming, taking days to be seen. Insidious can be progress. Onset is always there. She noticed it on that day while bathing, or someone noticed it, right? Present throughout the day following exertion. This is difficulty in breathing since last 2 months. Okay. Why do you think she could be having difficulty in breathing? Is it because of the large goiter which is pressing onto the trachea?
So it can be because of one is because it obstructs the trachea. The other, if there is any.
Look, Dr. Goitre. Can a thyroid? It's got cartilage trachea, right? It can't be compressed so easily, not by a thyroid until it infiltrates into it, right? So there must be some other cause of orthopnea. Can't relate thyroid to orthopnea straight away, right? Don't give it so much importance.
One of the reasons you must rule out is retrosternal. If it goes below the sternal, that it can produce that. Or
that is the only one.
70 years old individual, you must also not relate everything to thyroid. You must look for some other reason, whether she is going for
other
anemia.
Causes of thyroid, of breathlessness. Next slide.
Hello. Before that, Dr. Gitu, you told regarding this aggravation of the difficulty in breathing during lying down, that always is suspicious of a retrosternal extension, one. And second thing, there may be a mediastinal compression due to lymph nodes also. So anything which there is no space to expand, that will produce these. These are the signs which we should not ignore. And in such a patient who is having a long-standing goiter, and I think this is a very important history. That is, we should not ignore it.
Very important history when you are taking the history, especially when the patient is saying like this. Okay.
So Gitu, the point here is that you don't just associate orthopnea with the thyroid, large thyroid. There are other ways: retrosternal goiter, mediastinal masses. Could be plain cardiac condition at this age, right?
You have said there's no history of weakness of limbs. And in thyroid, what kind of weakness you are going to expect?
The proximal myopathy can be there.
Okay, Dr. Gitu, I would like you to just say, sorry, sir.
No, go ahead, sir. Go ahead.
No patient does not give any symptoms of hyper or hyper or hypothyroidism. You can't list the whole. There's so many other things, right? So just
when you don't actually suspect Graves' disease, best not to mention all these.
Yeah, that is not very common.
Yeah.
Just say the patient does not complain of any features or have features of hyper or hypothyroidism.
How did you elicit the history for a double vision?
Sir.
How did you ask the question for the patient? Do you have a double vision?
Or staring look for that matter.
From the bystand.
It's an inspective finding. Staring look.
Can your two eyes are seeing something too differently? That means one can study anatomy, one can study physiology, like that. Is that a double vision, or what do you mean by that double vision?
No, sir. I just asked the patient whether there is any vision issues for her, like
nobody can understand. For that question,
No.
nobody can understand. If you
What
have
sir
any
is asking, if you see one egg, you see it has two eggs. That's double vision.
Okay, Vito, all this is coming because you've listed all this. Had you just said that the patient does not give any history of hypersuggestive, hyper or hypo, this thing would not have come up, right?
Okay,
so
go ahead.
In an examination, don't try to give a whole list of symptoms of any disease.
Always
right? Never do that.
A good culture is not to say too much of no. You have put no constipation, no diarrhea. Instead of that, you can say bowel habits are normal.
Normal.
That rules out a lot of things and goes in the positive note. Don't say somebody no constipation, no diarrhea. That's what we don't expect in the postgraduate.
Okay, next slide, please. Okay, put hypertension in your medical disease, medical history, irradiation, surgical. Suppose she's undergone, what kind of surgery you are looking for?
Any previous history of thyroidectomy and now the recurrence?
So right, surgery of the thyroid. Suppose she's undergone appendicectomy, no history, surgical history in the past. We have to be specific, okay? Next slide, please.
This is a 70-year-old lady. You are asking the irradiation in the childhood. What do you have in the mind?
So childhood irradiation for lymphoma can predispose for a thyroid malignancies in
After 50 years.
After how many years?
After so many years.
It will take 10 to 15 years for the presentation.
But your history is now 50 years.
Yes,
And we have not thought that
yes.
it is a papillary carcinoma, you are not saying. So
Sir, he's
whatever
asking
it is, what we want, you, as a postgraduate, you ask only relevant question, or any question you are asked, you must be able to explain why you asked that question. Not just for the sake of completion, not just say the routine. Don't ask questions. If any question which is relevant to that. This lady has a hypertension, long back. So in there, your orthopnea, everything you can explain because of that congestive. She must have some cardiac disease. May not be related to the thyroid also. Go ahead.
Maybe simply she can
Gitu.
say there are no risk factors for malignancy.
Yes.
Because in a thyroid, we say risk factors of malignancy are history of radiation, childhood, and family history of cancers. So if that is there, it's even an indication for investigation to that extent. So maybe you simply say, like, she's already 76. You say simply that there is no risk factors for malignancy. And suppose a question comes, you can say about radiation at that time.
Gitu.
Yes, sir.
Why you ask history of diarrhea?
Sir, in hyperthyroidism, diarrhea is a feature, and also to rule out malignancy
In
like
hypothyroidism.
hyper,
Hyper.
What are the causes of diarrhea in case of the goiter? In case of thyroid?
thyroid. It is hyperthyroidism and also medullary carcinoma thyroid, sir.
What are the causes for that? What is cause for diarrhea in case of hyperthyroidism, and what is cause for diarrhea in case of thyrotoxicosis? Sorry, thyrotoxicosis and medullary carcinoma thyroid.
Sir, in medullary carcinoma thyroid, because of the release of serotonin, there can be diarrhea,
Secretory diarrhea.
secretory diarrhea. And
Okay,
in
and when due to mortality.
hyperthyroidism.
Okay, one more question you have asked. There is proximal muscle myopathy. So which steps or which activities are hampered?
Lower limb, sir.
Sir is asking, if you sit down on the floor, getting up would be difficult.
Squatting
Girdle muscles are weak.
Getting up from the squatting position will be difficult.
Upper limb can be also affected, proximal muscle. You can comb in the hair, patient will have
in the hair.
Even upper limb, right? Shoulders and hip joint.
Okay.
Should we go to the exam? Okay, next slide, please.
Proceed.
Examination comes.
Next slide, please. Next slide, please. Okay, what is by history? What do you think it is?
So from history, it is suggestive of a long-standing goiter with a retrosternal extension.
And patient is euthyroid.
That's what you are asking. You should have said that much earlier.
In thyroid, you must tell us about whether it's single lump or multiple lump, whether patient is euthyroid, right, and whether there are other lumps, right? Okay, go on. Examination.
So coming to the examination, patient is conscious, cooperative, well-oriented to time, place, and person. The vitals, pulse rate is 80 per minute, regular in rhythm, normal in volume and character. Blood pressure is 130/80 mm mercury in the right upper limb in sitting position. Respiratory rate is 16 per minute, and she is ephemeral. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Coming to local examination of neck, patient was examined in the sitting position and myself standing in front and behind the patient. Inspection. A single swelling in front of neck of size 16×10 centimeters, more prominent on the right side, extending between the borders of sternocleidomastoids of both sides. This is the picture. This is the left lateral view. A swelling moves up with deglutition and it does not move up with protrusion of tongue. Lower border is not visible on moving up with deglutition. Dilated and engorged veins are present on the neck and dilated veins are seen over the upper chest. Pemberton sign present. Upper borders are well defined. Lateral borders are found deep to the posterior border of both sternocleidomastoids. Surface of the swelling is bosselated. Skin over the swelling appears stretched and there are no visible pulsations. Palpation. There is no local rise of temperature and no tenderness. The swelling in front of neck more prominent on the right side of size 16 into 10 centimeters, extending laterally between the posterior borders of sternocleidomastoid bilaterally. Swelling moves up with deglutition. Lower border is not palpable. Superior borders are well defined. Lateral borders are found deep to the posterior border of bilateral sternocleidomastoids. Surface is bosselated. Consistency is firm and mobility, transverse mobility is present. Trachea was found deviated to left side. Cocker's test is negative. Carotid pulsations are bilaterally palpable but displaced laterally. Percussion, dull node over the manubrium sternae. Auscultation, there is no bruit. Examination of regional lymph nodes, no cervical lymph nodes were palpable. Examination for toxic signs, no eye signs and no tremors. Systemic examination, chest, air entry bilaterally equal, no added sounds. Cardiovascular, S1, S2 heard, no murmurs. Central nervous system, higher mental functions are normal. Per abdomen, soft, non-tender, no ascites or no organomegaly. Skull and long bones, no bony tenderness or no deformity. Coming to summary, 76-year-old female presented with a swelling in front extending to both sides of a neck of 10 years duration. She also had associated dyspnea while on lying down, more pronounced in supine and left lateral positions. On examination, she had a large swelling of size 16 into 10 centimeters in front of her neck, which moves out with deglutition. Lower border of the swelling was not palpable, and distended neck veins were seen bilaterally and dilated veins over anterior chest wall. Surface of the swelling was bosselated and she had tracheal deviation to left side. Carotids were displaced laterally and dull node was percussed over the manubrium sternum.
You said the swelling is in between the sternocleidomastoid. Then why the carotid pulse is shifted laterally?
Sir, in case of large goiters, the carotid is...
That is fine, not large. You said clinical examination, it is within the sternocleidomastoid. But your picture doesn't show that. It is going lateral.
Beyond
between the
beyond
posterior
that.
borders of sternocleidomastoid.
It go anterior to, can it go anterior to sternocleidomastoid? Thyroid?
Yes.
Yes?
Between the anterior borders. Yeah.
No, you can't go anterior to the sternocleidomastoid to the other side.
No.
Why not?
It is deep to deep fascia. Thyroids are present deep to deep fascia.
Deep to deep fascia. Deep to the vertebral fascia.
Investing layer.
Investing layer of deep fascia.
So that is, so you must be able to say how many layers of the deep fascia you have?
3 layers, sir.
3 layers. So it will be the investing layer will invest the sternocleidomastoid. Thyroid will be next layer, pretracheal fascia. So it can never go anterior to the sternocleidomastoid, posterior. But in your case, it is definitely extending beyond the sternocleidomastoid, coming to the posterior triangle. That is why you are able to see that even thyroid is. But you are saying more confined to the one lobe is more confined, no?
Right
More
side.
prominence.
More prominence is. And you are, what you looked in the Pemberton sign?
So for Pemberton sign, I looked for whether there was any congestion or sign of distress for the patient.
I couldn't appreciate on the video which you have shown.
But there was distress. Distress was,
distress was there, sir.
Okay. No, fine. It is fine. If you have noticed, it is fine. Okay. Why on raising the hand you are having the sign, and why not on the putting the hand down?
So on raising the hands above, if there is a retrosternal goiter present, it will cause closure of the thoracic inlet, and
Closure.
that can not closure, occlusion.
Okay, go.
No, Dr. Geetu, how did you palpate the posterior margin in both sides, that gland on either side, lateral edge?
Yeah.
How did you palpate?
You said you are palpated by standing behind.
And you said it is posterior margin on both sides you are able to palpate, no?
What is the method of palpation?
No, how did you do the palpation of that?
The
Each
Lahey's method, sir. By standing behind the patient, I can.
No. Lag is not standing behind the patient. No? The classical method, you are going to stand behind and keeping the thumb on the occiput. You do the passive flexion and extension of the neck and palpate only the anterior surface of the thyroid. The posterior lateral, you can have to come and stand on one side, push it and feel the posterior surface. If by both these methods, if you had identified any nodule, then only you should do the Kreil's method.
Kreil's
Otherwise,
method.
there is no need for a Kreil's method. Kreil's is only for when after you identified nodule. What do you mean by bosulated? What is mean nodular surface?
So bosulated surface generally has a bumpy surface, while nodular means we can it is already on a raised surface. Discrete nodules will be present, and we can appreciate the pits between the nodules.
Good. Okay. So here it is only bosulated. Even
Yes.
on palpation, it is bosulated.
Yes.
This swelling you are telling about, is it a single swelling or it is a clump of nodules? This huge swelling you are talking about. This size of the swelling you said now, is it a single lobe involved or it is the multiple nodules?
Both lobes are involved, sir, and isthmus is also involved.
Okay. Right.
Hello. Dr. Gitu, you mentioned about protrusion, this moment of the swelling on while deglutition as well as on the protrusion of the tongue. Why you wanted to see the movement with protrusion of the tongue?
So we have to rule out thyroglossal cyst, sir.
Such a large
Yes,
cyst.
such large
Quite
swelling,
inappropriate,
you want to rule
no?
out the thyroglossal cyst.
Very obvious thyroid swelling, best is not mention that, unless it's a very small swelling or so.
I just want to tell you something. Sorry. Gitu, I just want to tell you something. This is a post-grad exam. Sorry. This is a post-grad exam. You don't have to go through the whole of thyroglossal cyst and all that kind of thing here, right? You don't do that in your OPD, do you? So don't mention it here. Tell us whatever you do in your OPD. Right?
This is a very, very common question, but you need to answer. Gitu, why the thyroid moves with deglutition?
So we have the inferior constrictor muscle. There are two parts, that is the thyropharynges and the cricopharynges, which are attached to the thyroid cartilage and the cricoid cartilage respectively. So on swallowing or on deglutition, the inferior constrictor muscle contracts, and that will pull up this thyroid cartilage and the cricoid cartilage. Now, our thyroid gland is attached to this cricoid cartilage with the help of a suspensory ligament of Berry. So on deglutition, the cricoid cartilage moves up.
How many suspensory ligament of Berry?
On two sides, sir.
Okay.
So that's why it moves up on deglutition, sir.
It is a single thing which bifurcates, right? It's a single thing which bifurcates.
So it is
this is just condensation of the posterior layer of the least cervical portion.
You had done a Cock's test for this case, and how did you do the Cock's test?
So we have to push the one of the lobe from one side, and if it causes we have to see whether the patient has any stridor or not. If there is stridor, then Cock's test is possible, sir.
Why on inspiration or expiration?
Who?
Sorry.
On inspiration or expiration?
On inspiration, sir.
On inspiratory stridor.
Right.
So why do you get the stridor?
Sir, on pushing the lobe, it causes a luminal narrowing, sir. So that's why.
What is the shape of the trachea?
Shape of the trachea is.
What is scabbard trachea?
So long-standing multinodular goiter, on compressing the trachea, it will attain the be the scabbard trachea. Like
what is scabbard? What sir is asking? What is a scabbard? Trachea is like a straw, right? What is a scabbard?
Sir, it is a shield where we insert. We will keep the.
It's the sword. It's the sword, not the shield. The sword.
It is not.
So what does it tell you?
It is not anterior posterior, mediolateral. No? So it is compression conjugate. What is the normal structure of the trachea? Normal shape of the trachea.
It's tube-like structure, sir.
So it's a tube.
Tubular.
That means round tube like a esophagus.
Is it oval? Is it round?
Is it entirely covered with the tracheal rings?
Is the tracheal rings complete?
No,
is the
no,
tracheal
sir.
ring complete?
No, incomplete rings.
Then it
Where
cannot be.
Where is it incomplete?
Sir, except the first ring, the rest of the rings are incomplete. So they are of C-shape.
Where is the incompletion?
Is it
Anterior,
anterior or
posterior,
posterior?
lateral,
Incompletion is
medial?
posterior. Posterior, sir.
So it is tracheomalacia.
Tracheomalacia, when due to the long-standing goiter, sometimes this trachea the rings become soft, and that
So
causes
your Cocker's test, Dr. Goitre, your Cocker's test tells you that the patient could have tracheomalacia, right? And if the patient has tracheomalacia, what will it do? What is the problem related to associated with it?
So post-operatively, we cannot, intraoperatively, we cannot extubate the patient after surgery, because that can result in a sudden collapse after thyroidectomy.
So what do you do?
result.
So you leave the tube lifelong?
No, sir. We'll wait for because of the presence of the tube inside the trachea, that can cause inflammation and fibrosis. So later, after 7 days or 14 days, we can keep the
7
tube
days, 14
inside.
days. Hang on,
14 days
hang
you
on,
will keep
Dr.
the
Goitre.
No,
tracheal tube.
sorry.
No, initially,
keep the patient
initially you
intubated
retain
for
the tube
14
for how
days.
many days? That's the question. You don't keep it for 7 days all the time, no?
No.
When do you
So
do
we'll,
trial extubation? When do you do trial
we-
extubation? 24 hours, 48 hours?
Yes. After 24 to 48 hours later, we'll try for a trial extubation, and if it is not possible, then we can wait. And
You said the trachea is deviated, but you have never said any findings in favor of that during inspection or palpation or auscultation. No, suddenly you
Is
said
it
the trachea
deviated or is it compressed?
What was your finding to say it is deviated, tracheal deviation? Is it an
What is
inspectory
your
finding or palpatory or an auscultatory?
palpatory findings.
Can you get anything on the inspection?
Yes, sir. Trail sign.
Is it positive in your case? You are not looked for it.
Yes or no?
Yes, sir.
Yes, you have a very large swelling, which we can see that it's on the right side extending to the isthmus. And I don't think it's possible. We can't even see the lower
You're
borders.
not going to see trail sign in such a
How is
large
it
body.
possible?
Um,
Can
Huge
you see it?
gland.
I don't think it's
Very
possible.
huge gland.
I think all the seniors are agreeing to it. We can't see it. Then how is it
And-
Yes, you
possible?
can't.
And palpation, how did you measure, see the trachea?
So on palpation, first we have to look for the Adam's apple, and from the Adam's apple, we have to swipe down to see
You
to
can't swipe
palpate
down.
for the.
The thyroid is entirely occupying that area.
Yes, sir. I palpated for the tracheal rings at the lower end, and the tracheal
Lower
rings
end,
were
you said
found.
the retrosternal goiter. That means going beyond. So again, you can't see the trachea. Feel the tracheal
See,
ring.
basically, the problem is that you cannot palpate the trachea here. Number one. All that you can say inspection, you could say that the Adam's apple is shifted to left or right. Is that what you mentioned, sir, Jailal?
Yes, when given trial sign and this is, but probably you can say by the auscultatory finding. But in the
Yes,
auscultation,
auscultation is the only way.
Any undergraduate, you only said no bruit. Nobody asked you to look for bruit. What you heard normally. See, what in the examination, we are not going to see the theoretical knowledge. We are going to see by auscultating what you have heard when you are saying that what you heard there.
On auscultation, sir, tubular sounds, breath sounds could be heard. Tracheal
No,
sounds could be heard.
not breath sounds. Tracheal air. That's what.
Tracheal sounds.
Yeah, that you need to mention, and don't jump into say that always no bruit is there. And you said berry sign is, why do you get berry sign?
So berry sign is absent, absent pulsations, absent carotid pulsations, and that is because of the infiltration.
There is a blood flow in that?
Yes.
Then why there is no pulsation?
Because in malignancy, if there is infiltration of the carotid by the tumor, then we cannot feel the pulsations. But
Your case is a multinodular goiter with retrosternal extension, and you have said clinically no evidence of malignancy. Is it possible there's any benign condition where you will have a berry sign? Not present. Berry sign, you have two conditions. You have said there's no evidence of malignancy, whether there's infiltration or involvement or encasement of the carotid sheath. What about benign problem?
then long-standing thyroiditis.
Long-standing thyroiditis, this big. 4 types of thyroiditis. You have subacute, acute, chronic, or Hashimoto's thyroiditis, renal thyroiditis. All classics. Do you have a big, large swelling? Most common findings of these patients are pain, some discomfort in the neck. They don't come with swellings. Is it possible that a large, long-standing goiter, multinodular goiter, can push this vessel away
Yes.
from its normal position?
Yes.
A benign condition can push from its normal place of palpation, but a malignant condition will encase it, so you will not be able to feel in its normal place. Simple as that.
Pulse
Rajesh
is
sir,
not, pulse
Ajay
is
sir,
not generated there. Because
yes,
there is
it's not
no,
generated.
you are not able to see that. Okay. And you said there is a lot of dilated vessels you have seen.
In the upper
Something you
chest
said.
also. Upper chest also you're seeing.
Yes.
So what could be the reason?
Sir, if there is retrosternal extension, then that would compress over the
But you
superior
said the
vena.
retrosternal extension will compress only when you raise the hand.
No, sir. If it compresses over the great veins like superior vena cava, L walls, then that can result in dilated veins over the neck and chest wall.
It will be aggravated on raising the hands.
You will be having the normal dilated veins, but it will be aggravated on that, and the
Aggravated.
symptoms will be there for the patient.
Important sign, only two things. You look for vein and you look for trachea. Dilated discharge veins and dyspnea. That's it. Stridor. These are only two things. Last is clearly mentioned. Yes, sir. Sir, can we? Yeah.
And is it? Are you able to feel that movement on critical tissue fully?
Yes, sir. Except the lower border was not palpable, sir.
Otherwise, you are able to appreciate that. Okay. Something you said on the skin. Skin is stretched or something you have put.
Yes, sir.
So what do you mean by that? Skin is stretched? That indicates some other sign. So normal benign thyroid, do you think that the skin will be any changes will happen in the skin?
No, sir.
So is there a lateral movement of the thyroid?
Yes, sir. It's possible.
Can you tell any swelling in that region will have lateral movement but not vertical movement?
The lymph nodes.
Lymph nodes can have both. One is carotid body tumor. Second one is vagus or any zonoma which is arising from the nerve tumor. Both in the carotid. They will not have an up and down movement, but they can have the lateral movement. So in the thyroid, if it is not lateral movement, it indicates
Malignancy, sir.
infiltration to the prevertebral fascia. What is plunging thyroid?
So plunging thyroid it is seen in the intrathoracic area, but on increasing the intrathoracic pressure by coughing, we can see the part of the swelling in the neck.
How will you stage the retrosternal goiter?
No,
What is the definition
no,
of
no,
retrosternal
hang on. Ketu, plunging thyroid is that when you take a deep inspiration, the thyroid moves in. On expiration, it moves out.
How will you classify or stage retrosternal goiter?
So there are three grades based on based on the radiographic findings. Grade 1, it is reaching up to the aortic arch. Grade 2, from the aortic arch to the pericardium, and grade 3, it reaching up to the right atrium.
Left atrium.
Right atrium. Yes, correct. So this is on CT and imaging and clinical findings, substernal or retrosternal, deep or plunging, and intrathoracic coitus.
Intrathoracic. What is the blood supply to retrosternal goiter?
Sir, it can be from the, if it is completely intrathoracic, it will be from mediastinal vessels, and mostly it will be from the neck vessels only.
So the same blood supply. Yeah? There is no change in that. You are very safe. You can remove that.
Yes.
So how will you proceed for this case now?
So apart from the routine blood investigations, first I would like to do a thyroid function test for this patient, which is T3, T4, and TSH. And following that,
T3, T4, TSH, you want to do TSH or free T3, free T4?
So first, I would like to go with the T3, T4, and TSH only. And
You want both? You want to do T3, T4 or free T3? That is a question you asked.
Okay. Sorry.
What is
sir.
this? What is the gold standard? No, yeah.
Gold standard is free T.
How much is free? How much of thyroid is free?
Bound
Less
form,
than
free
it
form.
is less. Total bound form is more, sir. Free form is actually less.
I do not understand more and less.
But which is more significant, the free T4 or the T3T4 total for clinical symptoms?
For clinical symptoms of free T3, free T3 is more.
So it is 0.3 and 0.03. Only is free. Rest are all bound. Okay.
So next I would like to do.
Why do you want to do free T3, T4? I mean, test thyroid function test in thyroid. Because normally we say you do the investigation first, other investigation.
So I want to know. I want to confirm whether the patient is in euthyroid state.
So what you will do if the TSH is high? What you will do? TSH is low. What is the investigation you will prefer? So if TSH is low, you will not do FNAC. You will not go for a plan for an FNAC. If TSH is high, uptake scan can be
done.
So the TSH value is very important for you. Okay.
Dr. Gidu, like what Taylor sir was asking, if depending on the TFT, the second is the cytology of the quadruple assessment we have, like in plus triple assessment. So, is there any role for FNAC in thyrotoxicosis?
Any
yes
need
or no?
and any role?
Any need at all? That's yes or no? If yes, why? If no, nothing.
Can a Graves disease produce malignancy?
Sir has given clue.
Yes, sir. Graves disease can cause malignancy.
From?
Follicular cells.
So ultrasound, that is, sir was asking you, is there is any need for FNAC? So now you answer that question.
Yes, sir. There is a need for FNAC.
But it is very, very less than 5%.
Yes.
So
now you have answered sir's question, but unfortunately you said follicular carcinoma. FNAC you can diagnose follicular carcinoma?
No, FNAC cannot diagnose follicular carcinoma. Sir, you cannot
think before you answer. Your postgraduate, you cannot answer. You cannot find it out. Then why did you answer that? It is possible, like sir said, it's very less possibility in thyrotoxicosis. Papillary carcinoma thyroid is the only possibility that you will look for. You will go for FNAC. That's it.
Okay.
So, okay, now you made the mistake of follicular carcinoma thyroid FNAC. Is it possible to diagnose malignancy? Is it possible?
Pardon, sir?
Is it possible to diagnose malignancy? Follicular carcinoma, preoperatively, can you make a diagnosis?
From FNAC. Is there any tool that we have?
Yes, so there are recent studies of ploidy studies are there.
Ploidy status, yes.
DNA ploidies can be done.
Yes, DNA, RNA, you have aneuploidy and polyploidy. Which one is for which one? Which one is for which one?
So polyploidy for benign and aneuploidy for malignant.
Yes, very good. Yes.
You can have a spectrophotometry. There is something they are going to do. There are a lot of things.
Regarding the question on whether you can diagnose by FNAC, you must say first you will do an ultrasound to see if there are nodules. And if there are no nodules, many a time in Graves' disease you don't have nodules, then there is no indication.
Yes.
Yes.
Yes, agree.
Yes. So quadruple assessment, you have examination, TFT, FNAC, ultrasound imaging. I think with that you will get all the diagnosis: hypo, benign, malignant. Yes. Any role for antibodies?
Sir, if there is if we are suspecting in hypothyroidism,
patient has come with symptoms and swelling is not there. It's very late stage of swellings with probably eye signs. Diagnosis: Graves' disease, probably.
Graves' disease. So if there is
I am saying it could be a transient hyperthyroidism due to Hashimoto's thyrotoxicosis. How will you rule out?
Yes.
Sir, in Hashimoto's thyroiditis, there is a possibility of hashitoxicosis initially. That is, there can be a hypothyroidism phase initially.
And how do you
That's what
differentiate
sir
this
is asking.
hyperthyroidism?
Same question. Sir is asking, how do you find out if it is hashitoxicosis or Hashimoto's?
Sir, antibody test can be done.
Which
That
antibody?
is, thyroid peroxidase antibody will be
And
elevated in
thyroglobulin.
case of Hashimoto
And
and
thyroglobulin.
thyroglobulin.
Any other test you can do? Most
Uh,
importantly, uptake scan.
Radioiodine uptake study, sir.
So suppose it is a factitious thyrotoxicosis. Somebody who takes the thyroxine or Hamburg's thyrotoxicosis, and you have a thyroiditis that is due to endogenous thyroiditis, it is tumor ovary or something that can also produce hyperthyroidism. How will you differentiate that?
So with radioiodine uptake study, whole
No,
body iodine scan can be done.
no.
No.
The only way to differentiate exogenous and endogenous is assessing the thyroglobulin assay. So along with the thyroglobulin assay, when you have an endogenous, what will happen to the thyroglobulin also?
That will be elevated.
That will not be there when you have an exogenous. That means
Exogenous.
Hamburg or hyperthyroidism, you will not get. So there is a two things. That transient hyperthyroidism, you need to differentiate by antibodies and uptake scan. And exogenous or endogenous hyperthyroidism, you have to differentiate by along with the simultaneously assay of the thyroglobulin assay. So what you are going to expect in this case?
So in this case, it is
DFT is normal.
TFT
TSH
is
is
normal.
T3 T2 is normal. FNAC benign or malignant.
You have done
FNAC
an
is
FNAC. What do you expect in the FNAC?
benign only, sir.
Benign
FNAC,
only.
they will say benign or anything else. Isn't they right only like benign and send you that report?
No, sir. Bethesda classification. As per the Bethesda classification, they will report.
Now, what is Bethesda for benign?
2, sir.
1 and 2.
Yeah, 2. One is non-diagnostic.
Non-diagnostic, 2 is benign.
Can you tell that microscopy finding?
Sir, it will be cuboidal cells present.
Okay. What will be inside?
With scalloping of cells will be seen with pseudopapillary connection.
Okay,
Will there
Dr.
be a
Goitre,
collapse?
suppose this was a cyst.
Yes,
Suppose this was a thyroid cyst, large cyst. What would you do?
So first of all, we have to do a USG and confirm the
You've done it. You have done it. It says it's a large cyst.
cyst. So if it is large, then we can aspirate the fluid from the cyst and send for cytology study also.
And
Then the cyst study from the cyst wall can also be taken.
okay, and
make sure that it is a simple cyst and there is no thickening or shaggy walls. So a degenerated malignancy also can be cystic. So you need to be ultrasound
so you
will
got
tell
to
you whether
see
it's a benign cyst or not.
right. You got to see whether the cyst disappears completely or not. So after aspiration, you do an ultrasound again to see if there's a residual lump.
Color of the
Or
fluid.
there's no residual lump and the cyst refills. Then what do you do? Or you aspirate blood. What do you do?
What is the treatment for a recurrent cyst?
First time you
Before
have
going to
aspirated
recurrence,
once. You
sir
have
was
aspirated
asking,
once.
supposing it is refilling
But
immediately.
there is no residual mass. You have not felt any residual mass. It is only refilling. What you will do?
So we can go with lobectomy or
No.
No.
That's
You
why very
reaspirate.
specifically we said there is no residual mass. It is only refilling. You can do reaspiration.
reaspiration.
If it again refills,
Sir,
you can
pardon,
again
sir?
do a reaspiration. But if it's persistent, then you got to go in for surgery then.
Surgery, yes.
If you see a solid mass in between, then it is yes, you can write.
Is there any role for percutaneous injections if you know it is clearly benign and it is reaspirating?
So percutaneous sclerotherapy.
Percutaneous sclerotherapy.
No.
Very good.
No. Percutaneous injection of ethanol.
Yeah,
No, sir, I don't.
yeah, it is described for pure cyst, where it is benign and there are no features of malignancy or ultrasound.
I think another 10 years it will be only ablative surgeries.
Yeah,
Either
it
you are
is
going to use an
even for
RFA,
solid nodules. Even for solid nodules.
laser, anything you are going to use for ablation only, for the benign.
No, but it is there in Bailey already. If it's a
Yes,
pure cyst and benign, there is a
Yes.
role for percutaneous ethanol injection.
Ethanol injection and RFA and all that. Yes, ablative techniques.
Most of the things it will be coming on there. So what do you want to, this case, most probably colloid goiter you are going to expect. And what do you want to do for this patient?
So for this patient, I would like to go forward with the surgery, total thyroidectomy, sir.
Why do you want to do total thyroidectomy here?
So this patient has got compressive symptoms, sir. She has got difficulty while sleeping, while in the lying down position. So because of that, I would like to do a total thyroidectomy.
Supposing you found a retrosternal goiter on a USG, it was not on any kind of imaging, or she did not have symptoms, would you still go in for thyroidectomy?
Yes or no?
Yes, sir.
Okay.
Why?
So she can go in for complications later, and this is a long-standing multinodular goiter also.
What is the age of the patient?
70 years. 70 years.
70 years. What complication you are expecting here after carcinoma?
So she can have compressive symptoms again, later.
And more importantly, if a malignancy develops, you can't find it out because ultrasound is not useful, clinical examination is not possible. So there are two schools of thoughts, but asymptomatic ones, generally the recommendation is to go in and do a total thyroidectomy if it is retrosternal.
But it is more than 4 centimeter. I think it is better to go for thyroidectomy.
Gitu, yes. Dr. Gitu,
sir.
Here, this is a 76-year-old lady.
Elderly.
Right? If she's just colloid goiter, why going through total thyroidectomy?
So for this patient, she is having compressive symptoms, sir.
You can go for a subtotal or near total. Why go for total? Total has its own problems: hemorrhage, parathyroids, recurrent laryngeal nerve. You're not going to gain anything out of it. So you should answer about your patient rather than a general. Right? Had it been a young lady, could have thought of that. 76-year-old, nothing. No fun of doing a total. Do you get me? Yeah.
Rajiv sir, but nowadays we don't do subtotal at all for any
I know,
case.
I know. But 76 doing a total thyroidectomy.
And sir, nobody knows how to do a subtotal.
Sir, now the safest surgery is total, then the subtotal.
No,
yes, sir. Absolutely agree.
I said near total, not subtotal. It's near total.
Near total.
Near
Right.
total, leave
Near total.
the tissue around the parathyroids or around this so that you don't damage the parathyroids.
Yeah.
Total
Yeah.
is for
Sir,
this lady is not.
what I have seen many.
Sir,
Though
the thing
we
is,
say
the
total,
intention is total. Intention is total, but ultimately it will be
most of the time,
near
uptake
total.
scan will show there is some tissue is there. Here.
Yeah. So all the time we do total, it is really near total only.
What I mean is by near total is that we deliberately leave tissue around the
Yeah.
parathyroids.
Yeah.
That's near total.
So in this patient, what difficulties you are expecting doing surgery?
So I'll try with the neck incision only.
You said your patient is hypertension
What
for 20
difficulties?
years. Patient has a dyspneic patient. Getting an assessment itself is a difficult, but on the surgical table, what is the difficulties you are expecting?
So on surgical table, intraoperatively, sir, there can be a difficulty in relieving the. So if it is, there can be difficulty in relieving the retrosternal part.
So what are the methods? What are the steps you will do to relieve the retrosternal goiter?
Sir,
Simplest thing that you'll do first.
First is
method. What is the method? What is the method that What is the method that you keep the patient in the position? What do you call that method?
Process position.
The Rose method. What you will do to the neck in a retrosternal? How much more will you? How much more will you hyperextend it?
Hyperextend.
Be careful with the age of the patient because
cervical spine will.
But okay, 1, 2. Now you put the cervical thyrotomy. You've done the incision. Yes, Cocker, classic.
So with the
this particular swelling is this big. It's crossing. You have said it's crossing from here to here. So The classic incision is how many centimeters?
Focus incision is 2 centimeters above the suprasternal
No.
notch.
How many incision is how long? We didn't ask how many finger breadths above the sternal notch.
Okay, between the anterior borders of sternocleidomastoid, sir.
What is the length of that incision? Approximately.
15 centimeters, sir.
16 centimeters. You're making a collar from necklace.
Between the anterior borders of sternocleidomastoid.
How much would this be approximately? What is in Sebastian? What is really? Approximately 4 to 5 centimeters hardly is the incision that we will give. But in this particular case, because it's extending, you have to go from one sternocleidomastoid, you put a spike. That's it. That's all. Okay, you put the incision. Second, next.
So
What do you want to do
strap muscles can be divided, sir.
Where will you divide the strap muscles?
On the upper part, sir.
Why would you want to do it?
Which strap muscle you will divide?
Sternothyroid, sir.
Sternothyroid. Which
how many types of strap muscles you know? How many are there?
4 types, sir. 4 are there, sir. Sternothyroid.
Two pairs. It's superficial layer, deep layer. Yes, because it's connecting this way from down to top and superficial, deep layer. Yes, answer sir's question. Yeah.
Sternothyroid, thyrohyoid, sternohyoid, and omohyoid muscles, sir.
Which is medial most?
Omohyoid.
Omohyoid. When you open the midline critical fascia, what will be the muscle first layer?
Superficial. Which is a superficial one?
Superficial is sternothyroid.
Thyroid cartilage, HTC.
Sternothyroid has to go above that, no?
I'm not sure, sir.
No, but you cut the sternothyroid. Okay, the medial upper end you are going to cut. What will be the neck position you keep?
Hyperextended neck, sir. Ross's position.
It is a Trendelenburg or anti-Trendelenburg? Head elevated or?
Head down, sir.
Head down.
Head down. You want to relieve the veins, and make it empty, So make it
always
head up.
Keep it head up.
10 degree head up.
Head up.
You put reverse Trendelenburg
advantage. It has a disadvantage. Advantage is bleeding will be less because veins will be collapsed. Disadvantage, air embolism is more. Chances of air embolism is more. Okay. So you continue with that. Now, how do you ligate your superior thyroid?
So superior thyroid is ligated close to the gland, and we have to ligate it separately. The superior thyroid artery and superior thyroid vein should be ligated separately near the pole.
So you will separately ligate superior thyroid vein and superior thyroid artery, or yes, anterior superior thyroid and posterior.
Superior thyroid artery has 2 branches. That's what sir is asking. Anterior branch, a large one, and the small posterior branch. Will you ligate both of them separately?
So here,
what would you do?
We ligate thyroid artery and vein separately.
Oh, vein and artery.
What is that? What is that rare complication that happens if you ligate these 2 vessels together?
Sir,
if you ligate both of them together, what is that rare complication that happens? It's very rare. It's only
when you ligate together, what will happen?
What will happen?
What are the important structures in the upper pole, near the upper pole?
So superior thyroid artery, superior thyroid vein, and external laryngeal nerve, sir.
Anything else?
External laryngeal nerve.
Anything else behind, of course. Anything else? Any parathyroid there?
Pardon, sir?
Any parathyroid nearby?
Parathyroid gland will be there.
Near the superior pole. Yes or no?
No.
Say yes and get out.
No. Superior parathyroid, they're not seen there. In above the junction of recurrent laryngeal nerve and inferior thyroid artery.
Where it's entering into the cricothyroid. Okay.
Oh,
you said external laryngeal nerve. Is it external laryngeal nerve or something else? It's very easy to remember this. In an exam, it's like today I was taking a class during thyroid. Will you be making the external examiner happier or the internal examiner happier? Whom will you be close to?
External examiner.
External examiner. It is the external branch of the superior laryngeal nerve. What is the why is that nerve very famous? Do you know what is the name of the nerve? We are running short of time also, I think.
Say the name of that opera singer.
Sir has given clue also. Very
It's,
famous.
it's a criminal nerve.
Since then it has become very infamous. Because both of them, the recurrent laryngeal nerve involvement, it causes hoarseness of voice. The other one, what is the significance of the external branch of the superior laryngeal nerve? Why is it important? Sir has said some singer. What's the catch?
Opera singer.
Dr. Gidu, you are a singer, no? What happens if we have knocked off your external branch?
It tenses the vocal cords, sir. It is a
It's a modulator. It is a voice modulator. That's the nerve of Gali Kursi. You're postgraduate. You should know everything. For answers should come. Your exam week. Next week is exam.
Gali Kursi.
Yes. Sahai sir, Rajesh sir, any? Yes.
What artery is there in the inferior thyroid pole?
Sir, inferior thyroid vessels, inferior thyroid artery and vein.
Are you sure? Inferior thyroid artery is in the inferior pole?
You only have veins there. You do not have artery. In the inferior.
Yes, sir. Inferior thyroid veins will be there. Inferior thyroid artery on the lateral side.
So where do you ligate the inferior thyroid artery?
Inferior thyroid artery, we'll go with capsular ligation, sir. We won't ligate the trunk.
Why not you ligate away? Old teaching is ligate away, no?
Yes, sir. But we have to save the parathyroid. Blood supply to the parathyroid should be preserved, sir. So that's why we go with capsular ligation.
What will happen if
parathyroid
is removed?
So there will be a patient will have hypoparathyroidism. Okay.
So how it manifests?
Then the patient will post-operatively patient will have circumoral numbness and tingling sensations.
Okay, so how will you manage that? Suppose you come for the round next morning and the patient has all this. What will you do?
So we
Any
have
sign? Any
yes,
sign
sir.
you do on the bedside?
Yes, sir.
To
Shostak
confirm.
sign and Shostak sign
Yeah,
and
you've got
cautious
those signs.
sign.
Okay, Dr. Geetu, you got those two signs. What do you do now?
Yes.
So if these are positive, then first of all we have to check the level of calcium. Post-operative calcium should be checked.
No,
first.
already says we have already figured out it's hypocalcemia.
Hypocalcemia.
If we got to
Then-
Shostak cross, what do you want to do? Just answer the question.
We'll
You're in the ward.
we'll give the patient injection calcium gluconate 10 ml 10%.
How much?
10 ml 10% in 100 ml NS over 10 minutes.
10 ml.
Over 10 minutes, then
What it contains?
what is the full answer
Anything
to the
else?
question? What the patient is in hypocalcemic tetany? What will you do? There's no full answer.
Anything else?
And we'll go with a 24-hour infusion, sir. If the patient is
Fast or slow?
Anything
Fast
else?
infusion or slow infusion?
slow IV, sir.
Rajesh sir is asking anything else. Say something more.
Anything else?
What else?
And
How will you manage hypocalcemic tetany?
Anything else?
Apart from calcium, what do you give? Any
Magnesium.
vitamin?
Vitamin D3 and calcitriol can also be given, sir.
For what?
Can also, no, you have to give. Not only can, you have to.
We have to give.
Okay.
For what?
What about,
For what you want to
suppose
give? No,
Right,
calcium
okay.
you want to give for what? It is not for intravenous calcium.
Oral
It is
calcium.
for absorption. So now you are
Absorption.
in a treatment, an acute emergency with a intravenous calcium. That there the calcitriol do not play some role. It plays a role when you are giving a oral calcium. It has to be absorbed and taken for that.
Right,
And you must
okay.
know what it contains. It's not, you cannot say postgraduate cannot say I will give 10 ml. So one company 10 ml may contain something, one other company may have a 10 ml.
10%.
How much milli equivalent? What is milligram?
Yeah, 10% of a calcium.
Okay, go and check it.
Okay, Dr. Geetu, last question from me. When do you give calcium gluconate and when do you give calcium carbonate?
The calcium gluconate will be given as an immediate treatment for hypocalcemia, and calcium carbonate is a formulation of oral supplements, sir.
I'm sorry. Look,
Sorry, sir.
calcium carbonate is not given in a cardiac patient. It is given when the liver is not functioning, you give calcium carbonate. When the liver's function is normal, you have to give calcium gluconate. right? Calcium carbonate, the calcium levels rise very high, fast, and they can affect the heart. So the cardiac condition, this lady, probably she's elderly, she could be having some cardiac problem. You don't give calcium carbonate. You have to give calcium gluconate. If the liver is knocked out, you have to give calcium carbonate.
When
You
will
get
you
me?
say transient hypocalcemia and when will you say permanent hypocalcemia?
Duration.
Okay. Sir, if it subsides within 2 weeks, sir, it is transient hypocalcemia, and if it persists
No. It is much longer.
2 months,
Still longer.
sorry.
6 months, it is a transient hypocalcemia. What is spurious hypocalcemia?
So spurious hypocalcemia, this is immediate post-operatively because of the stress and antidiuretic hormone release. There can be decreased calcium and decreased albumin, but the ionized calcium will be normal, sir, in
What is
spurious.
facetious hypocalcemia?
What
What
is
will happen to the liver? SARS talked about the liver cell disease, no? Liver disease and the carbonate. And what will happen to the cirrhosis and the calcium level?
Sir, in
Which is-
cirrhosis, there can be hypoproteinemia, and that can result in hypocalcemia.
So every rise less than 1 gram of albumin, you have to raise 1.8 milligram of the calcium level. That
Yes.
is what is called. It is wrong. What is hungry bone hypocalcemia?
So there will be
What the associated, you must measure the phosphate also. So normally hypocalcememia will have a hyperphosphate level will be increased. But here the both hypocalcemia and hyperphosphate, it is a hungry bone. It's a parathyroid problem you are going to have.
Yeah, so
Normally,
people take
calcium
enough
and phosphate, if you multiply calcium and phosphate levels, it is equal to 40. So if calcium is 10, phosphate will be 4. If calcium is 9, phosphate will rise similarly, okay?
Gitu, you answered very well. So in the thyroid, you will ask one question that what is euthyroid 6 syndrome and what is Refitov syndrome?
Pardon, sir, I
So
don't.
T3, T4 will be normal.
Very simple. This is something very simple questions here. This is a PG question. Sick thyroid syndrome. That is a clue is there in that itself. What sort of patients?
The euthyroid patients will be
Or what type of euthyroid patients? The age of the patient. Any patients, any critical care patients, or something like that in the stressful ICU patients, aged,
Anyway, she
elderly.
said she doesn't know. You answer.
So the T3,
I don't know
T3,
that.
T4 level may be low, but TSH will be normal. In those people, they are more prone for mortality is high. There is septicemia and other things that are there. Similarly, there is another condition called Refitov, where you have a T3, T4 will be high, but still the TSH will be normal, where the tissue will not be responding much to the organ. That is why the T3, T4 level is poor. So here, in both the condition, you have a TSH level will be normal. What is reverse T3? What is T3? What is the formula for T3? You have 3 dash, 5 dash, 3, 5.
3 dash 5 dash monoiodotyrosine. Iodotyrosine.
So depending upon which layer of the in a triad, I mean, both the lower thyroid lobules are combined together, and which is going out. You have normally 4 molecules: 3 dash, 5, 5 dash, and 3. So then which one is going out? If the outer layer is going or inner layer going, depending upon that, you have a T3 and reverse T3.
Gitu, all this is given in Harrison. Thyroid is given very well in Harrison. So,
one of the best book for good students to read is Harrison. Then you must read at least the main topics like breast, thyroid,
Endocrine system.
Harrison.
Parathyroids, adrenals. Just last question. What Rajesh, just to complete. Rajesh sir had said something, one organ which he's the only one who mentioned, something to do with liver in endocrine system. Is there any drug where you used to treat the patient that causes a hepatotoxic effect? Dose dependent.
I couldn't.
Any drug which causes hepatotoxic.
Any drug that you use that causes a problem to the liver.
Yes, sir. Propylthiouracil is hepatotoxic, sir.
Yes, propylthiouracil causes liver failure, and that's why they don't give it in the Western system. We have other drugs for if the patient is allergic to carbimazole or methimazole. The treatment would be liver transplantation most of the times. so they don't use it. Yes.
What
It's
is
an
the indication of
antimetabolic.
propylthiouracil?
So, pardon, sir.
Indication of
Indication.
propylthiouracil.
Propylthiouracil can be given in patients, pregnant patients and
No,
lactating mothers.
not all pregnant patients. It is only in the first trimester.
First trimester
Because
First
patients.
trimester.
second, third trimester, the toxicity is more. With the liver toxicity is more. So you will not do that. It's only in the first
Yes.
trimester, it is can not crossing the placental barrier.
Yes.
Can.
I think
Yes,
we've
sir.
done.
Yeah, it's
Yes, sir.
time.
Yes, sir. We have, yeah. Thank you.
Okay, Gitu,
So,
very well done.
Can I make a comment?
Yeah,
I
please,
was
sir.
Yes, sir. Peter, sir. Yes, sir. Peter, sir. Yes.
yes, I was closely watching both discussions. Wonderful, excellent discussion. Congratulations to the presenters and more congratulations to the teachers. It was very informative. And only one comment about the first presentation that doctor's description of the abdominal lump, the palpation. I think she has to improve on the description of the abdominal lump. And of course, you discussed many controversial things, and some points are still controversial. Different examiners may differ. But you tried to solve the situation almost amicably. And that was an excellent program. Congratulations once again. And of the two candidates, I think Gizu did slightly better than the other candidate. Thank you.
Yeah, well done, Guido.
Thank you, Peter, sir. Rajiv, sir, and Jailal, sir, your closing remarks.
Babu sir is here.
ഇല്ല sir, വന്നില്ല. Dhananjay Babu sir അങ്ങോട്ട് on the way. He was traveling. He called
Yeah,
me and said he can't make it.
and
He's on the phone, so it was hanging.
just in case he is there, just inviting. That's all.
Yes.
Yeah, Gitu, I'd like to tell you something.
What I am happy is the mindset of Guido. She is never perturbed. She has never shown any kind of anxiety or tension. She was able to take all the questions with a smile and able to. And see that calmness, which really merits. That's what we expect on a postgraduate.
In spite
Yes.
of examiners like Jalal sir and
Well,
Rajiv sir, he is still composed.
Yeah, Gitu, I'd like to tell you something. Look, you get a case of thyroid definitely in exam. Thyroid, what is important? Whether the patient is hyper or U, whether the swelling is multiple or single. If it is single, solid thyroid nodule, importance is of malignancy. You have to rule out malignancy in solid thyroid nodule. If it's multiple MNG, you must know about the malignancies and the management. You'll have to go through the whole gamut of types of thyroid swellings. You've done well, very nice. I'm impressed.
Thank you, sir.
Thank you.
Thank you. Thank you.
Thank you.
I feel the credit for what Jailal sir and Rajiv sir said goes to PTT sir, because he's been behind tuning our postgraduates, carrying them from day one. So I think that fear has been embedded into them.
Thank you. Thank you.
She's our exam going PG, sir. She's doing exam on 24th.
No, I think, look, in the examination, it never reaches this level.
It's level.
Her basics are okay. I mean, she would pass any day.
Thank you.
Thank you, sir. Thank you so much. Thank you, sir.
Thank you, sir.
Thank you, sir.
So thank you very much for your presence for today, sir. It was great. Kanagol sir, your
Thank
closing
you.
remarks, sir.
Thank you.
Manohar sir, we see each other every week. So
Yes, sir. Yes, sir. Thank you. Thank you, sir. Thank you.
Guna and Uday sir, would you like to give any comments? I think most of the others have given.
Sir, excellent discussion, sir. Both the candidates were good. Particularly the second one is too good. I would say the examiners were even better. Much. Thyroid has been a very good discussion. I liked it, sir. Thank you so much for the opportunity.
Uday sir and Nishi sir.
Sir, excellent discussion, sir.
Good. Uday sir, any
Dr.
comments
Das,
from you?
Dr. Das, we'll meet in Assam sometime.
Yeah, definitely, sir. You are always welcome, sir. Just give me a ring. That's all.
Manohar sir.
Yes, sir. Nice discussion. The second candidate was really very, very good. Excellent. She was able to answer all it was literally tug of war between Jalal and the candidate.
Yes.
Robin was saying all the credit goes to PT Thomas, sir.
Yes, sir. Very good. Candidate is well prepared, sir. We have to give.
Thank you.
Consider taking MCH endocrine, Dr. Keetu.
Yes, sir. Yes, sir.
Yes, sir.
Sure, sir.
Yes, sir. Thank you, sir.
So good luck, everyone. Geetu, do you have any questions to be clarified or any doubts to be clarified from the examiner? This is an opportunity to give back the questions to them. Okay. So thank you, and I thank Sunil sir and the entire thing. Robbins was almost with
Thank you,
me like last 2 weeks.
Thank
He's been in touch
Thank
with
you.
that. Thomas sir, thank you, sir, and I
Thank you.
wish you could join us all Fridays whenever
Okay.
possible.
Okay,
God's
boss.
grace, we are running 280th edition or so.
Oh, good.
So it is happening. So all Fridays except the ASICON week, we have 55 weeks in a year. We run the class. So
Okay,
all
good.
of us, all of you can be part of this. This is an open platform. There is nothing to involve like you cannot, I cannot. It is an open platform. That's how we've been running. All of you are welcome all Fridays. So with the permission of the faculty, we'll call the session a close. I
Special
thank
thanks
both.
to Robin, Dr. Robin
you.
Judge for, sir, Kanawal sir, special thanks to
Yes,
Robin
sir, of
Judge for
course.
giving a lot of in the input in this one,
Of
chat
course,
box.
sir. He is the one who has
Lot
been
of points.
wanting this session to happen. He has been very systematically reaching out to us in the last 2 weeks and very effective communication. Gitu was promptly sending mails and Robin was keeping in touch. And it was a pleasure to work with them. We look forward for more opportunities, sir. Pushpakri
Yes,
can come in
definitely.
anytime.
Yes.
Thank you.
Thank you, Jailal sir. Thank you, Rajiv sir. I'm
Good night,
always
everyone.
in on Friday sessions.
Thank you.
Good night, sir.
Good night, everyone.
Good night, Manoj.
Thank
Thank you,
Good night,
Vijay sir.
everyone.
Thank you, sir.
Good night.
Good night, sir.
Thank you, sir.
Good night.
Thank you. Close.